So good morning, everyone. Thank you for joining us for the Lung Cancer Chakravyuh Untold Story, Unmet Need, Unique Solution. I would now like to introduce our program director, Dr. Purvish Parikh, medical oncologist from Mumbai. Over to you, sir.
Thank you very much, Kashish and Kavina Creation. It is a pleasure to be here with you and talk about something that is unique and different. Uh, Taking the backbone of lung cancer and seeing what else we can do to, help our patients with unmet needs. And the first session is by Dr. Mehboob Basade on how we can help our patients get Mediclaim and insurance companies to give reimbursement for treatment against cancer, which is oral treatment or TKIs or OPD therapy. So over to you, Mehboob, for the first session. As everybody
Thank
knows,
you.
Dr. Mehboob Basade is a medical oncologist from various hospitals in Mumbai, and he is my dear friend.
Thank you. Thank you for, and good morning, everybody. Thank you for inviting over here, Kashish and Dr. Parikh. So the topic what has been given to me is Mediclaim tip for oral TKI therapy, because one of my patient of late has got it, and how we fought the case with the patient. That's why I thought probably let's share with everybody so that everybody is clear on that. Next, please. So, there was one survey conducted among almost near 377 doctors with the 8 questions regarding Mediclaim by Dr. Parikh, and this was published in Indian Journal of Medical Sciences. Next, please. So the first question was that how many of, in what instances have you experienced the insurance companies refusing to give the cashless approval? And I think cashless approval is mostly for an indoor patients. And 55% said that yes, majority of times they have faced the problem that it was refused by the companies. Next, please. Rejecting the claims, by the insurance companies, I think everybody has faced this problem. Rejecting in whichever way, rejecting outright or rejecting in the in lowering the value to be reimbursed. And as you can see, only 4% of the doctors said that they have never faced any problem of rejecting the claims. I'm surprised. Yeah. Next, please. And 3% said that yes, they have experienced that the companies have not reduced the claim amount. Otherwise, almost 97% saying that their companies have reduced the amount, and more than 10% in almost 70% of the cases. Next, please. So do they ask for the clarification? And I say yes. I mean, majority of us do give clarifications, and how I give, I will explain you also that. I mean, that if that can make somebody to get the claim, I mean, one can use that route as well. Next, please. So, what were the problems or issues related to your patients? And, only 10% said that they had no issues. The other people said that treatment without admission was a problem. That is like an OPD treatment. If there is a new treatment, again, either whether it is a biological or whether it is a TKI or whether it is an immunotherapy, there are issues. Then there are certain fine prints in the policy terms. So those are also issues. And again, oral treatment is being mentioned over here, and some undisclosed pre-existing illness. So those are the also things probably they will not reimburse for the patient. Next, please. So how many times we have been successful in giving a letter and insurance claim is accepting that? In almost half of the times, yes, they do modify their order and they do give the benefit of the insurance to the patient. And in almost half, there is no benefit in that. Yes, please. Next, please. So how do I give that? So please click it. So I give that, first tell them that what is the definition of the chemotherapy. And somehow, I don't know, I can't read down. So the chemotherapy, by definition, it says that any disease which is treated by chemical substances is chemotherapy. Now, TKIs are also chemical substances. Biological therapies are also chemical substances. It is we defined among ourselves that they are TKIs, they are biological therapies, they are immunotherapy. But look at the structure. Structure is a chemical structure. So if it's a chemical substance, then it is a chemotherapy. That's the gross definition. And chemotherapy doesn't mean that only what oncologists use, but chemotherapy could be antibiotics also, could be any other thing for which are the drugs which are using for cardiac failure or whatever. So chemical substances which have been used for the treatment are the chemotherapy drugs. And there was another definition from the NCI also saying the same thing. Next, please. So here is my patient who had a non-small cell lung cancer, and he has an ALK positive. He was started on crizotinib, and we all know that it's an expensive treatment and it does not require hospitalization. Next, please. So this insurance company again rejected the claim because it's an outpatient treatment and it was an oral treatment. So that was rejected. So then the patient went to the court, went to the ombudsman. Next, please. And in ombudsman order, which I will show you, that they said that they have received several complaints regarding denial of the claims of the oral chemotherapy, modern chemotherapy, for example, liposomal drugs, hormonal therapy, and gene therapy. So IRDA has brought out a circular where the modern drugs cannot be denied on the treatment, whether it is an outpatient or OPD patient. Next, please. So this is an order from February 2020, which showing that you have to reimburse fully to the patient. And I have shared this with you even in our WhatsApp group. Also, I have shared this. You can take this, and it's at the related line which is mentioned. It's a very important thing, and one should read that how intelligently this fellow has given the order, and the award was their full reimbursement of crizotinib for this patient. So that's very important message that I want to pass on you, saying that yes, you can fight and fight on these parameters. Next, please. So in the award, they said that yes, 1,75,000 fully given. It has to be paid within 30 days and binding on the insurer, whether they have not further appealed against it. Next, please. So the patient got the money back. So it's a great news, and the order covers the three things. One is that the treatment without the admission, new treatments are also included, and the oral treatment is also included in it. And I think that's my last slide. Thank you. If you have any questions, I'm ready to answer those things.
Wonderful, Mehboob. This is very good news for all of us. Oral treatment, new treatment, and treatment without admission is all covered. And I think this will help a significant number of patients across India. So I'm sure that this is of immense benefit. And if there are any questions, they will all contact you directly. Kashish, we can move to the second panel.
Thank you so much, sir. The moderator for the panel is Dr. Amish Vora, medical oncologist from New Delhi. His panelists are Mr. Jose Peter, co-founder and CEO at Arogya Finance, Dr. Rajesh Bolam, medical oncologist from Hyderabad, Dr. Vinayak Maka, medical oncologist from Bangalore, and Dr. S.P. Somashekar, surgical oncologist from Bangalore. Over to you, sir.
Thank you, Kashish, and thank you, Parikh, sir, for this opportunity. Can I have my next slide, please?
Sure, sir.
So I think Dr. Mehboob has set up that those who have insurance, we have to fight tooth and nail so that patients are benefited out of it. We are covering another aspect of this topic where if the patient do not have enough money, they do not have enough insurance, can we still help them? So I must say the topic is unusual, but it is very relevant. Organizers have put this. Just give you two of my patient background where I had tried to help them. And these are real cases. 21-year-old boy, diffuse large B-cell lymphoma, planned for R-CHOP. Family could afford 20 to 25,000 per cycle. There was no insurance. Rituximab is must, and how do we manage addition of rituximab? Do I give him only CHOP? Do I give him R-CHOP? How do we do that? The second case, 54-year-old female widowed mother from Jammu. Son just was selected in army, started earning recently. Patient had multiply relapsed ovarian cancer, needed Avastin or bevacizumab as part of treatment. They knew it is palliative treatment, but son wanted to do everything for mother. He said that my salary is not enough to afford every 15 or 21 days of bevacizumab. What do we do that? Next slide, please. So, when such patients come, they look like this. And we also want to help them. And please understand the figure says that 1 in 4 cancer survivor, that means at the completion of treatment, goes bankrupt, which we never realize. We feel we have victory, patient's cancer is treated, but 25% of them go bankrupt. Next slide, please. So my first question to both the medical oncologists on the panel, Dr. Rajesh Bolam and Dr. Vinayak Makka. What would you do with these patients in your practice? We can start with Dr. Rajesh.
Sir, considering for in this rituximab scenario, we can ask for Sparsh, sir. There's some program called as Sparsh for especially rituximab, wherein which we can get 1+1. And with financial assistance, if that 1+1 also cannot be managed, then we can ask a company. One of my patients, we have asked for 1+2 also as an exceptional case for rituximab. And for similarly for bevacizumab, many of the companies are offering 1+1 upfront, and few companies at the request of clinician are giving 1+2 as an exceptional case, provided if you give a letter.
So Rajesh, you would depend on the pharmaceutical company's assistance to help these patients. Vinayak, would you do the same?
That is for one option, sir. That is
Right.
one of the options. And for other options, especially not for this clinical scenario, maybe more expensive drugs, wherein which, especially recently, one of my patient was started on Tecentriq. For them, we have taken with the help of Roche through third-party financing like Project Life and Arogya financing. The price can be divided
so we
into
have
month.
Mr. Jose Peter for explaining that.
Okay.
Thank you, Rajesh, for opening up that. Vinayak, do you have anything else to say apart from what Dr. Rajesh has said?
Yes, sir. The thing is, what he said, I agree with it. There are two kind of patients. The people who can afford is different. There are borderline affordable patients where what Dr. Rajesh told can help us to complete the treatment because it's curative intake. Sometimes people can't even afford CHOP. For them, we have government schemes like we have BPL card provided. That is free in our institute. One. Second is people don't have that. We use something called
Vinayak, let me stop. We have very less time. We are concentrating on middle class people who are neither for government nor for this. Yeah. So let's talk of those.
What Rajesh said is more options, sir.
Okay. Perfect. So can I have next slide, please? So what did I do about these patients? I gave personal loan from my own organization on plain paper in writing that I will return money in X amount of time. There was no legal documentation because I trusted these patients. NHL patient got cured, CA ovary patient passed away after 1 year. 2 years since the loan, they are still not being paid and I'm still calling them up again to pay the money. Next slide, please. Similar experience when I was working as a medical director for a US-based pharma company. The company had a drug for multiple sclerosis, which has to be taken for 2 years, 3 times a week. 1.8 lakh rupees per month. Came out with India-specific EMI and couldn't succeed. Next slide, and we come to Mr. Jose Peter. Mr. Jose, this is one of the background. This thing was put at one of the hospitals. 0% ब्याज दर बेहतर इलाज की सुविधा. Next slide, please. So you have multiple questions and you have 4 to 5 minutes, Mr. Peter. You'll have to answer all those. Please tell us about the scheme which you are familiar or you are working with, answering all these questions which are put up on the slides for the benefit of all of us.
Okay, how many minutes?
You have 4 minutes, sir.
Okay, just to set the context, taking off from the insurance, one of the latest studies says that even in addition to all the problems that were described there, even those people, which is only about 23% who are insured in this country, even those who are insured, about 60% 94% of those who are insured are underinsured to the extent of 60%. Correct. So even if it is payable, they don't have the insurance available. And so therefore, that's also one of the reasons why insurance is not doing the job it should be doing. Second, on a lighter vein, in insurance, to take the insurance, no questions asked, but when you have to take that policy, the claim, all questions are asked. In Arogya Finance, we do exactly the opposite. We ask all the questions upfront and we ask no questions thereafter. So to take care of people who do not have health insurance, we have come out with something called an Arogya card, which is a pre-approved medical loan. So anyone can come to us, ask for a loan to be pre-approved. We will pre-approve a loan if they are eligible, up to 5 lakh rupees. And once it is approved, they can take it multiple times over the next 1 year to treat themselves or any of their family members. Which hospital you go, what treatment you do, none of these are questions that bother us. So therefore, we have made something that is very flexible, which is, which helps the patient and their families. So that is our construct. We have, last word on that, we have pioneered this concept of medical loans in India. So in terms of the loan amount, we fund up to 5 lakh rupees. But when we work with pharmaceutical companies, like somebody mentioned about Roche, when we work with pharmaceutical companies like that, we structure loans which are even higher than that. The values can go up, but because then they are structured for a particular disease condition, that suits the patients and to the oncologists, etc. But as a general rule, loan amount is up to 5 lakh rupees. How do we decide patients' capacity to pay back? Yes. So, when we brought in our healthcare finance initiative, one of the major struggles we found was that many of these patients in the middle do not have adequate income documentation, credit history, or banking habits. How do you lend to these people? We were frustrated. And in that frustration, we thought about building something called a psychometric tool. So we designed a psychometric test using our experience in HR in the past. And so we started looking at people's integrity, their intentions to repay, and their risk-taking nature to decide whether we can lend to them or not. So we have the ability to lend to people anywhere above the bottom of the pyramid. That means below poverty lines we can't lend, but we can lend to anyone above that. So that is, and we are able to do that very quickly. I will describe that. Okay, today we have 2 ways in which one can apply. You can go to our partner app and then you can apply, or you can apply on our website. It takes about 6 minutes to apply. At the end of that application, a significant number of patients will get an instant approval. Those who do not get that instant approval will be taken to a smartphone-based psychometric test, which takes, unfortunately, another 8.5 minutes. But once you take that test, and if you pass, they will also get approvals. And once the approval is given, we quickly get on the phone, have a telephonic conversation, and within 3 hours, we can send out a formal sanction letter to the patient as well as to the hospital treating them. Loan repayments can be from anywhere from 3 months up to 36 months installments. And that's where, so the construct of our product is, one is the loan amount is higher, can be very quickly taken. It can be taken by people who do not have a lot of documentation, which is generally required by a normal banking institution. We are able to do that quickly. And we have also structured a longer tenor, up to 36 months. Sometimes we even go beyond that based on a specific program that we develop with a pharmaceutical major.
So what is the percentage of interest of this 36 months?
Yeah, so it varies.
And sir, you'll have to go a little faster.
Yeah.
My
so
apologies for that.
Yeah, no problem. Most of the loans, we have 0% options available, up to tenors up to 12 months. But when the tenors exceed 12 months, some interest in the range of 5 to 10% needs to be paid by the patient. Okay, and the money is dispersed directly to the hospital so that the hospital can start the treatment without a problem. The risk is entirely that of Arogya Finance. it is our responsibility to engage with them and collect the EMIs.
Thank you so much, sir. Can we move to the next slide, please? I think we would like to know more about it. We already covered that there is nothing like zero interest EMI, but I understand that your idea is to help and patient has to pay some money. We will not go into how company makes profit because that would be a separate thing. Next slide, please. So, Mr. Peter, it's very important that if you give the details of this on the email, all of it can be circulated and all of us can avail the benefits of these Arogyam facility.
Certainly.
Just a question, how many patients so far have availed this across India?
Yeah, across India, about 25,000 plus patients have benefited out of our program.
How many defaulters?
We have, unfortunately, we have about 3.19% of our loans, which are 90 days overdue,
Okay.
which is still within our parameters. So we are comfortable with that. Even during this lockdown, we have lent for oncology to hospitals like Fortis, Manipal, Lakeshore, Sahyadri Hospital, you name it, and all those things. Even in the lockdown, we managed it all digitally, and disbursements were made in time to those hospitals.
Excellent, sir. Dr. Somsekhar, in May 2016, one of the interviews you were asked, how is Manipal different from other cancer centers? So in terms of financial facilitation, how are you different? If you can give your experience, unfortunately, we have only 1 hour and 40 seconds, 1 minute and 40 seconds. Sorry for that.
No problem. I'll go ahead with this. We noticed a lot of patients don't complete the treatment. Some take one chemo here, then they go out in the other place and the chemo is changed, or surgery, they're not able to complete, radiation not. About 4 years back, we set up a finance, SOP in Manipal, and we came out with following guidelines, which has been very robust since last about 3 to 4 years. Now, number one, Manipal Hospital called all the top pharma companies, 7 to 8 who make most of the chemo related drugs. Number one, they made a microfinancing with them, where if their drug is fully used, they do zero financing. See, the way it happens is we have 4 systems. People who have credit card, debit card, who don't have either of them, but they ensure the treatment is completed in one hospital. Then it is 0% finance. See, you wrote a slide, there is nothing called free meal. How does the hospital makes? If somebody has a credit debit, in our hospital, if you walk in, everywhere there is a board, no documentation required, and then 0% loan if the EMI is 4 to 6. So we have tied up with all the banks where just their credit card, debit card, they do 0% finances if the EMI is 6. Now we have another place, people who don't have credit, debit card, any form of them, then CIBIL score above 750, a copy of their PAN card. Then if a particular X company drug is chosen, for example, Roche, AstraZeneca, or anything, hospital has a financial microfinancing tie-up with them. Their drug used, it is zero finances. So, and you know what is the motto? Everywhere it is put, loan sanctioned in 2 minutes. Loan sanctioned in 2 minutes.
Wow.
So we look at whether you have credit card, debit card, neither one of them available, but you take one X pharma company. So then the pharma company cross subsidizes with them, but pharma company is not directly involved by rule. So there is a microfinancing working with Manipal, with that pharma and this. 1,100 patients have utilized since last about 2 years. And then if they use this particular area, we are able to do this. So a lot of patients are using, and 80% of them have completed. Default is in the tune of 1.8%, which hospital absorbs. So we have a dedicated PFC in each department and a center where they go, they look at which category they fall. And then if they say in 4 EMI, they're going to finish it in the next 12 months, it is going to be 0% finances with no documentation required, because we have a cross subsidy from the company, but through a microfinancing company. If they avail through credit card, it is 2.3% in 1 year. And if it is debit card, it is 3.2%. But the most important thing is no other documentation, sanctioned on the same day directly to the hospital, parked in their name, which means they're obliged to complete the whole treatment in the same hospital. So if they move not there. So this is available and it's working extremely well, not only for chemo, for surgery and radiation, as a full package which is available for us.
Thank you, Dr. Somsekhar. I don't have time to conclude, and I conclude the session here. Thanking Mr. Jose Peter and Dr. Somsekhar. I would like to have details reach out to email through everybody and over to organizers.
Thank you. Thank you so much.
Thank you. I've forwarded all the details to Purvish sir, and maybe he'll be able to see the schemes that is being offered at Manipal.
Thank you so much. It's an amazing thing, Dr. Somsekhar.
Thank you very much. We'll probably have another session in the future so that we have more time to discuss. Over to Kavina Creations for the next part.
Thank you so much, sir. Over to the next part. Our interviewer is Dr. T. Raja, medical oncologist from Chennai, and our interviewee is Dr. S.H. Advani, medical oncologist from Mumbai.
Professor Advani, you are a guru to all of us. You are a pioneer in the field of medical oncology, and you have 45 years of experience. It is a great honor for me to interview you. Good morning, sir.
Good morning. How are you?
I'm doing well, sir. Thank you.
Thank you.
Sir, in 1974, after your MD, I learned that you secured your first job in Tata Memorial Hospital in medical oncology. So what was the attitude towards the treatment of lung cancers in 1974?
Yeah, when I joined Tata Memorial Hospital, attention in medical oncology to the solid tumors in general was very poor. And surgeons used to say, what you can do in solid tumors? You better limit yourself to only the blood related diseases. Even support care was very, very preliminary. The only support care was go home.
What would you do to treat these patients in the 1980s?
I think it was very clear those days that we used to use endoxon, maybe methotrexate, 5-FU, play around with that, and the response rate was negligible. The first time when we were really excited, and that was the excitement not only with us, but all over the world, was the introduction of cisplatin. That made a big difference as a single agent as well as in combination of these. So the commonest protocol was cisplatin with cyclophosphamide. These two drugs were used, and we used to say fantastic response.
Sir, in 1995, in the space of advanced non-small cell lung cancer, a meaningful work, a meta-analysis from 52 randomized trials was published in the BMJ, which showed that for the first time, cisplatin-based chemotherapy was superior to best supportive care. At that time, how did the medical oncology community accept that data?
Oh, it was dramatic. We did not need any statistics to say to use this. We could see the difference. And if you use in 10 patients, you know that this is working. And therefore, it was accepted very easily. The problem in those days was only the cost. The cisplatin 10 milligram dose used to cost in those days 200 rupees.
In the early 2000s, the ECOG 1594 data was published, which showed that 4 different platinum doublets, when platinum was combined with either taxanes, docetaxel or paclitaxel and gemcitabine, showed somewhat similar efficacy and similar 1-year survival of around 35%. So that doublet, and was that a practice-changing data, sir, at that time?
Yeah, I think it had a major impact because before that, everybody from different institutes used to claim that this is better. Best is paclitaxel cisplatin, or best is gemcitabine and cisplatin, or the third one will say etoposide and cisplatin, the best one, and good results. But when this data came in, everybody realized that everybody is in the same boat.
Sir, in 2008, Dr. Purvish Parikh and Dr. Scagliati published an important paper in the JCO, which established the role of pemetrexed in non-squamous non-small cell lung cancer. Suddenly, pathology and adequacy of the tissue became important. What were your thoughts at that time?
Well, I think that was really very remarkable in the sense that before that, all of us were sort of not bothered about whether it's a squamous cell or whether it's an adenocarcinoma, and also our pathologists. But also, most of the time, they'll write non-small cell lung cancer, and nobody, used to force them to give us more diagnosis in detail. And it's only with this realization that everybody, all pathologists, started talking about it, that how to recognize adeno, how to recognize squamous, although I'm sure they knew about it. But still, that ability on a small tissue to give the diagnosis was a challenge for them. Particularly in those days, there was no core biopsy. It was all FNACs. Adenocarcinoma in those days was rare. In India, there are published papers. They say adenocarcinoma is small percentage. And today you can see the change, that how adenocarcinoma is more prominent.
Sir, in 2009, maintenance therapy with pemetrexate and switch maintenance with docetaxel became popular. That's when these studies appeared. So the concept established itself. How did you adopt maintenance therapy in advanced non-small cell lung cancer? What were the challenges when you counsel patients that you have to be on a prolonged maintenance therapy, and how did you execute that?
I think the whole concept about maintenance treatment was absent in all the solid tumors. Everybody used to believe maintenance treatment is of no value. But I must say that it's only because of the amitrexate that people recognize to use it to continue to maintain the response. So I think the important thing is not the maintenance treatment like we do it in the leukemia, where the patient is in remission. While here, the patient has a visible disease, and then also you are using the maintenance treatment. I think that difference, even today, some people don't realize.
So around the same time in 2000, late 2000 and 2009 and 10, the ECOG 4599 and the AVAIL study came to our attention. And that established the role of bevacizumab in non-small cell lung cancer. How did you see the arrival of VEGF inhibitors in non-small cell lung cancer?
Yeah, I think these biological factors did come in. But I must admit that we never saw a phenomenal response with them. And we knew that this is not going to make a major impact in terms of controlling the disease. So it was not really, one was a cost factor and second was the response factor. There was not much difference whether you add the all these bevacizumab and all in such a situation.
So the targeted therapies for non-small cell lung cancer appeared in early 2000. The early phase 1, phase 2 data in 2002, 2003, and some of those photographs when we see, we were so excited. And they showed to improve some survival with gefitinib and erlotinib. And the IPA study was published in 2009, which showed that gefitinib is superior to chemotherapy in EGFR mutated patients in first line. So in the 2000s, what were your foresight, and what did you see for targeted therapies as a new option emerging in non-small cell lung cancer?
I think it was miraculous. It was really miraculous. But we could see with our own eyes that patient is receiving no chemotherapy, and with a tablet, the disease can disappear. That was really phenomenal. And I think we really accepted it very quickly.
So in 2009, AFCO had a presidential address on personalizing cancer care. And suddenly molecular testing became inevitable. But in 2009, what did you see as a landscape for precision medicine, personalizing medicine in non-small cell lung cancer?
I think actually it became clear to us long before. And we used to be involved in our department with a lot of basic work. Luckily we had that time along with us Cancer Research Institute. There are many PhDs who are doing lot of molecular work, but those technology was slow. So we used to share our ideas. So in those days, when I used to start the lecture, I used to say that olden days of drug discovery by serendipity that just came in is over.
Sir, you are one of the most respected medical oncologists in the country. Patients come to see you after multiple opinions, and sometimes that can be a dilemma. How do you counsel these patients when they come to see you for a second, third, or even a fourth opinion?
Yeah, I think it's very important. Requires a little skill, I must say that. And one of the first skill that has given me this chance of counseling the patient is the smile. I can tell you that. The moment patient enters, he looks at me and he says, fine, half of my disease is gone because I'm seeing you. Many patients come and tell me that. And I don't see any other thing except the smile. Second thing is, of course, I think it's very important to show and keep some hope. I think it's important. We cannot be inhuman. I think it's inhuman to tell somebody that, look, go home, but you can always tell them, fine, you go home, eat well, become strong. Let us see, we may have some new discovery for you. So you see, you are giving them a 1% hope. Patient lives on the 1% hope also. First of the time, the patient knows. But you don't have to tell him that. Few things which come by experience. I think like how to convey the diagnosis, how to discuss with the patients, and how to really make sure that the treatment is palatable for them.
Nicely said, sir. Patients come to you hoping for the moon. I have seen some of your patients. They adore you. I have seen that with my own eyes. Sir, I learned that you were born in Pakistan in 1947, just before the independence. And then you were denied a seat in MBBS in Grant Medical College in 1965. And then you had to fight with the dean and secured your seat. You took up medical oncology in 1974 when it was a neglected branch. You have overcome several odds in life. Sir, what is your advice to the medical oncologists when they face challenges in life?
Yeah, you see, basically, all of us have a challenge throughout their lifetime. Challenge never stops. Today, one challenge is over, the next challenge is in front of you. So that's how one has to use your own potential to overcome those challenges. I think that's the only way that we can progress in future. And that's what really happened in our, some by your own effort, some maybe by luck from the Almighty. So I think we should also in our practice, we should never forget the Almighty. And I always remember this line that we treat and he cures. So I think that's one thing which most of us should really remember.
Sir, this is a memorable day for me. It was a privilege to interact with you. Thank you so much, sir.
Thank you. Thank you very much. Okay.
Thank you very much, Dr. Raja and Dr. Advani, for this wonderful interaction. We will now move on to the next session. Over to you, Kashish.
Thank you so much, sir. Our next speaker is Dr. Ullas Batra, medical oncologist from New Delhi. Over to you, sir.
Here we go. Can I have my slides, please?
Sure, sir.
Okay, so you guys will have to bear with me. There's some electricity issues at my home, so the internet is coming on and off. So I may just disappear, and that is why I have not put my photograph. Also, the video is off. Also, this is one fact that electricity is not there, and second fact is that it is Sunday morning. And even if it is Dr. Parikh's symposium, it's time to take a late bath. So I am not going to put my video on today. Okay, let's go to the first one. So I have been asked to speak about the molecular tips and the untold story of liquid biopsy in lung cancer. And the moment I searched the untold story, you know, all these sad looking stories come up over about MS Dhoni throughout the years, MH370, India's partition, Delhi Roids. I didn't want liquid biopsy to be an untold story. So next slide. So I wanted to say the liquid biopsy in non-small cell lung cancer is a story which is waiting to be told. I mean, because I think it's got a huge potential in this. Next one. Next one. So let's take a walk down the memory lane. I mean, lung cancer 50 years back when probably Dr. Advani was talking about was basically like this: non-small cell lung cancer and small cell lung cancer. Next slide, please. And lung cancer now, as we can see, is basically about lung cancer now is basically about EGFR mutant lung cancers and ALK and ROS and MET and everything. Next slide. So what we know is that the survival in lung cancer has actually improved with the use of the targeted therapies. And as Dr. Advani rightly said, you know, I mean, in 2009, when the Scagliotti and Dr. Parikh's paper got published, the target therapy versus non-target therapy became a huge issue in lung cancer actually. Next one. So that brings me to the first line of oncology, and that is, next one, biopsy, 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 biopsy. I mean, you know, you cannot go ahead without biopsy. However, the second law of oncology also is there, which basically states that tissue is always an issue. Next one. This is a slide from the US over there, which says that 22% of tissue quantity is not sufficient for molecular testing. And we know in today's era that without molecular testing, you can actually not go ahead. Next one. Also, there is a, so if you can see this slide properly, you know, the tissue is not like one. You have this blue areas, you have this yellow areas, you have this, Dr. Sevanti will be able to tell me which area is it. I can call it light pink or peach or whatever, it doesn't make a difference, but there's some other color which is not blue. So as a man, anything which is not blue is some other color for me. But for tumor also is, you know, there are multiple things. Your biopsy may turn out to be somewhere from the blue, somewhere from the yellow, somewhere from the peach or whatever color it is. Also, so there's an intra-tumor heterogeneity. Next one. In addition, there is also inter-tumor heterogeneity. So that the thing which goes away from lung to the bone, which may be very different from some metastases which go from lung to the liver, which may be also different from something which goes from lung to the brain. So there is an intra-tumor heterogeneity, there is an inter-tumor heterogeneity. Next one. So that is why you cannot biopsy everything over there. So is there any other way to look at this? Definitely there is a way to look at this, because there's always another way. That is what Dr. Parikh has always told us. Next one. And that is something called as liquid biopsy. So rationale for liquid biopsy can be three. It can be clinical, it can be biological, it can be logistics. Clinical, I told you, they can be tumor heterogeneity, they can be insufficient tissue, you may not have an IR person available. The turnaround time in COVID especially can take more than 14-15 days. Biology, they can be intra and intertumor heterogeneity. Logistics also could be the cost of them. You may have to repeat a biopsy, you can have a inadequate intervention support. Next one, please. So let's come down to liquid biopsy. You know, when we say liquid biopsy, it's not as simple as your tissue biopsy is. You know, so liquid biopsy can analyze three things. One, it can analyze the CTCs. One, it can analyze the extra cellular vesicles, and the third, it can analyze the circulating tumor DNA. Next one. And the thing of which is very most important right now is not the CTCs, it is not the extracellular vesicles right now, it is actually circulating tumor DNAs which we actually see. Next one. So these are the potential applications of liquid biopsy in non-small cell lung cancer. You can use them in early diagnosis, for prognosis, for real-time monitoring, for immunotherapy, for identification of therapeutic targets and resistance mechanism for metastasis development. But the next one, please. But the real applications of clinical utility of liquid biopsy in 2020, next one, is actually in identification of therapeutic targets and resistance mechanism. The rest few are things for the future, 2025. Hopefully, when Dr. Advani will give us a 55-year experience of his in medical oncology. But at present, this is what I'm going to focus about. Next one. So the real next one. So to me, the molecular tip that I have been asked to give, the real clinical utility of liquid biopsy in 2020 is about biomarker detection in de novo metastatic lung cancer. So like all the people who have just spoken with me, just look at this slide properly. Next one, please. So liquid biopsy, next one. So liquid biopsy can basically be used to detect these two things. Number one, in de novo metastatic lung cancer, you use NGS. For EGFR mutant lung cancer specifically, you can use PCR-based techniques for real-time monitoring to detect T790M mutations and other things. So please remember, if you have to have a biomarker detection in addition to EGFR, please use NGS. For EGFR mutant, you can use ddPCR, you can use COBAS, you can use Serascreen, etc. So very important slide. Next one. So let's start with some, this was all theory. Now let's go down to practice. Now, has a tissue versus liquid NGS in de novo metastatic non-small cell lung cancer been ever compared? That's the first thing which we always say. So this was a study by Natasha Lake group, which was published in Clinical Cancer Research. Next one. And this was called the Nile study. Next slide. So this is the Nile river which was there, because I did not really wanted to show you what the Nile study was. So the Nile study actually showed the biomarker detection rate. So 32% of all the patients basically had tissue biopsy. Patient basically had tissue biopsy. Patient basically had liquid biopsy. So what we found out here was that tissue found out 12 samples which were extra. The cfDNA found out 23 samples which were extra, and 48 was concordant between tissue and liquid. Next one, and the non-inferiority trial P was less than 0.001. Next, please. And if you can see over here, this is the most important. The proportion of all alteration detected by tissue was 67%. By cfDNA was 87%. So in the case of tissue, liquid biopsy added to 33% extra. And if you use only liquid biopsy, tissue added to 13% extra. Now that was something which was an eye opener for me actually. Next one. This was also the Nile study said liquid biopsy is equal to tissue biopsy. There was also a study called as complete study, which again compared around 6,948 samples. Ultimately 543 samples was analyzed, which had both liquid biopsy report and the tissue biopsy report. And then these people were treated with the drugs. And you can see the positive predictive value of liquid biopsy was 98%, 98%, 100%, 92%, and everything. So if you have a mutation detected on a liquid biopsy by a good lab, definitely you are, that's true. So the specificity is very, very high. The sensitivity is something which we are going to, which we have to go and take it with a pinch of salt. Next one. So at this time, there was a joke between complete or finished. I am sure since it's a family audience, I'm not going to say it, but how can I ever make a presentation without a wife joke in between? Even if it is on a Sunday, the wife is in the next room right now. I can see Dr. Sevanti smiling. I think she knows the joke. Next one. So we will talk about the clinical and the complete and the finished thing later. So I said about NGS, liquid biopsy for all biomarkers, complete study, Nile study, absolutely okay. Now let's come to EGFR mutant lung cancer. Next one, please. Next one, yes. So to detect EGFR mutation in the EGFR story, you have three ways. Number one, you have how to detect EGFR mutations at diagnosis. Number two, can you do a real-time monitoring? Number three, can you find out T790M mutations at resistance? So that is using RT-PCR techniques or a PCR-based techniques. Let's not confuse things. So for all the biomarkers, you use NGS. For the only specific for EGFR, you're using PCR. So this was the first test which was rejected, which was the COBAS EGFR mutation test. Next one. And there was a trial which was FAST-ACT2, and this trial was presented by Tony Mock et al. In CCR 2015. Next, please. And if you please see something over here, the specificity of cfDNA to detect EGFR mutations was 96.5 and the sensitivity was 75. So if it is positive, it is positive. That is a dictum. Next one. And again, you see over here, if you give an EGFR TKI based on the plasma report, that is also very, very predictive. And the results are almost the same. Next one. So that was the COBAS, high specificity but low sensitivity. Then came the TheraScreen RGQ plasma PCR kit, and again, as we can see the red ones over here, a very high specificity, but and a slightly better increased sensitivity also. Next one, please. Now, ddPCR is something which was always there. Again, so the sensitivity increased from COBAS to TheraScreen to ddPCR. Next one, the specificity actually came over here, which was 100%. So that is the point with all these liquid biopsy report. If you have something which is positive, it is positive. If you have negative, you need to confirm it with a solid biopsy report. Next one. So this was an article in an ESMO review, which basically said, next one please, and just look at this, the phase 4 IFM trial. Again, they said specificity high, 99.8, sensitivity was 65.7. This was by TheraScreen. And the last line, please, which said on significance, 12 people without tissue samples were discovered to have EGFR mutations via plasma testing only. So yes, plasma testing will get some people who have been missed by tissue biopsy. Next one, please. So this was our own data. Next one. By RGCI, ddPCR, and we demonstrated it was done on around 120 patients, and we had 100% specificity and 87.5% sensitivity. We are shortly going to come up with the data of a comparison between tissue biopsy, COBAS, and ddPCR. Watch for this space. We are going to have an ASCO, hopefully, publication for this. Next one. So, are there any characteristics that may improve performance of plasma-based testing? Yes. As the tumor size increases, the amount of DNA that it sheds increases. As the metastatic burden increases, it increases, and the other tumor features which improve in the detection of in the shedding of the cfDNA. Next one, please. So now we spoke about NGS initially. We spoke about primary detection of EGFR TKIs. Now let's talk about the liquid biopsy to detect resistance to TKIs. Next one. And I am not talking about money heist right now. Next one. Okay, this was the Aura trial, which basically compared that whether you detect, whether you have T790M detection by solid or by tissue, the reports were almost same. In tumor tissue, the overall response rate was 62%. In plasma, it was 63%. Next one. And again, osimertinib act if you have a tissue biopsy T790M or you had a liquid biopsy T790M. Next one, please. So this was the statement paper which came from IACLC. Next one, so everybody who has by and large, just next slide, please. So please look at this slide. Now this is the most important slide. So patients with advanced treatment of NACLC, your tissue specimen is sufficient. Yes, go and do. If it is no, you do ctDNA. If your target is positive, that basically means that you can go and treat people on this. Again, very important. But if it is negative, go back and do a tissue rebiopsy. This article got published in Annals of Oncology 2018. Please go and read. Next one. At the progression, in fact, they advocate that you should not do a tissue biopsy, do a liquid biopsy. Next one, please. If your liquid biopsy is positive, treat for the tumor. If it is negative, then do a tissue biopsy. Next one. Next one. Next one. What does the future behold? Next one. So we can actually do a dynamic monitoring by liquid biopsy, and I am thankful for Dr. Purvish Parikh's group. The ICON actually gave us a grant, and we are also we saw the dynamic monitoring of EGFR mutations in biopsy, and that paper is also going to come. Next one. Liquid biopsy can actually monitor MRD. You do surgery, see if the patient has got CTCs or by this thing at there. If the patient doesn't have, you can actually avoid chemotherapy. Next one. And the liquid, there are some applications of liquid biopsy in immunotherapy. Next one, please. I think next the blood TMB, BTMB was equal to the solid TMB. Next one, please. Okay, so here we are, 42 seconds. My conclusion. Liquid biopsy is fast emerging as a valuable tool in the management of non-small cell lung cancer. It has a high concordance with tissue biopsies and far more easier and convenient. It has got an established role in the detection of primary resistance EGFR mutations, high concordance rate with tissue NGS. It's got an emerging role in immunotherapy. Next one. So this is a question which always gets asked, will liquid biopsies replace tissue biopsy? Next one, please. My answer is no. Next one. But they will be complementary to each other. Liquid biopsies like Donald Trump, you can love him, you can hate him, but you cannot ignore him. Next one, please. And this is my last slide. Next one. Stay safe. The cases are increasing. Do work. It's precaution over panic. Thank you. And I hope I have not exceeded time. Thank you.
Thank you so
Thank
much.
you very much, Ullas. That was perfectly on the time allotted to you. And you really dug into the meat of things. So I'm sure that everybody appreciates your beautiful insights. And again, I would like to take this session forward in more details at a later date. We'll now move on to the next program and over to Kashish.
Thank you so much, sir. Uh, our moderator is Dr. Vamshi Krishna, medical oncologist from Hyderabad. His panelists are Dr. Navneet Singh, pulmonologist from Chandigarh, Dr. P.N. Mohapatra, medical oncologist from Kolkata, Dr. Krishna Kumar Ratnam, medical oncologist from Madurai, Dr. Gansham Biswas, medical oncologist from Bhubaneswar, Dr. Bharat Bhosle, medical oncologist from Mumbai. Please note that this session is sponsored by Boehringer Ingelheim. Over to you, Vamshi sir.
Good morning, everyone, and nice Sunday morning. I am following Ullas, and as always, I should follow what he does. So I do have internet issues as well, and I probably will switch off my video in a while. So I would be talking about a case, and I request all my panelists to kind of be concise and also stick to what we would do here. Okay, academics is good, knowing the trial is great, but let's also see what we can do for our patients and what we routinely do. Again, a request, let's not talk financial for everything. Let's not say if affordable. Let's assume that affordability is there for one of our patients. So this is a 58-year-old gentleman, Mr. RB, a non-smoker, presenting with a cough and mild chest pain. He was detected to have a lung mass, skeletal mets with mediastinal nodes, 2 or 3 skeletal mets, not a huge burden of disease. Adenocarcinoma, EGFR mutation positive, DEL 19. Next slide, please. So if I can start with my panelist, in this EGFR positive patient, Dr. Navneet, what would be your expected, next slide, what would be your expected goal of therapy for this patient?
It's obviously metastatic disease, so you don't aim for a cure, but you definitely attempt to achieve at least a partial response if feasible. PFS would, with any of the first or second generation TKIs, would be close to a year plus minus a couple of months, but you could aim to extend that by either using osimertinib or using a combo of chemo plus gefitinib. And plus, we should always, whatever the treatment, always give bone directed therapy in such cases.
Dr. Ghansham, next slide, please. Would you look at PFS as the most important here, or would you look at the OS, or would you look at the response rate? What is your, can we just go back? Yeah. What would be your goal when you sit across with a patient?
Since it is an exon 19, I know that it is a common mutation, it is a druggable mutation. So I'll definitely have all these three. So initially responses, then PFS, then OS. So
okay, the reason I'm asking is we know that we have different drugs which can probably give you different results. You have some drugs which probably give you a better OS, some which give you slightly longer PFS. So what is the one thing that you're really looking for in a situation?
The final goal will be definitely an OS. The final goal will be definitely OS.
Okay, Dr. Bharat, when patient comes in front of you, what's the thing that you are looking at? Can we improve the OS, or what exactly is your thought process?
For EGFR positive lung cancer, for the first line therapy, oral TKI, my first goal is to prolong PFS.
First goal is to prolong PFS.
Yeah, that ultimately gets transmitted to oral.
That's fine. Dr. Ratnam, do you agree with this? Is the PFS the first thing that you would look at, or would you? What would you be your aim?
I totally agree. My initial goal will be PFS. My initial goal will. I'm looking at. Yeah, my initial goal will be a PFS.
Perfect. Next slide, please. So we have first generation, which is gefitinib and olatinib. Dr. Navneet alluded to that. We get around 10 to 11 months about it. Second generation afatinib gives you around 10 months again in a trial setting. Dacomitinib slightly better, around 14 months. Third generation gives you around 18 months. A TKI VEGF combination will give you around 16 to 17 months. A TKI combo again gives you 16 to 17 months. So Dr. Navneet, when I get back to you on this, you're looking at these different options. So what would be your choice? Would you look at upfront sequencing, or would you look at upfront PFS front?
You have to factor in several other things. I mean, you don't want me to talk about cost, but if you leave apart cost, then you also have to look at patient wishes, whether he or she is willing for a combination treatment or just wants to be primarily domiciliary based with an oral tablet a day. The second would be the performance status of the patient. I don't remember if you mentioned that or not.
Performance status is 1. He is fit gentleman, 58, no comorbids.
Right. So, I mean, he is somebody who you could consider for a combination, whether it's a chemo combination or a VEGF combination. So, you could consider for that.
So,
and
No, so my question really is that among all of these options that I have given you, a combination FPF is actually lower than that of a third generation, but you are okay with giving a combination first. Any particular reason on that?
So the combination of PEM-carbo and gefitinib has reached OS, which was probably higher than osimertinib in both the Japanese and the TMH trial. And so
just a correction, TMH trial has not reached. TMH, in fact, is one of the lower ones. It's around 27 months or 28 months. So that we cannot really say. Fair enough. The Japanese trial reached 50 months, is what you're saying. Correct. Fair enough. Dr. Ghanshyam, again, the same question to you. We have all these options in front of you. Patient says, I'm okay with whatever you feel is the best for me.
So I will prefer like the sequencing, because sequencing is what we are looking at all metastatic solid tumors today, because so you don't put all eggs in the first basket. No, so you have a future plan. So now we can start on second and go back to the third. We can start on third and go back to something else. So that will be my sequencing.
Okay, so just a matter of course, this is what people ask. Your only 60% of your initial people are going to go on to a third generation TKI. The remaining 40 do not go on to a third generation. So that way, is your sequencing going to matter to you, or you're okay with giving?
Yes, still that's okay. So 60% is a good number of patients. No?
Perfect. Next slide, please. Yes, Bharat.
Yeah, so you cannot have overall survival goal without PFS 1 and 2. Then when you are treating your patient with just a PFS 1, which is good for osimertinib, and put that drug in the front line, you don't have a data to increase your PFS 2. So it makes sense to think about PFS 1 as well as PFS 2.
Absolutely. These are options. That's why I want to know how we are doing it nowadays. We know all this data. We have been discussing this for the past 6 months. So I'm just trying to bring out what we are doing in practice. So fair enough. Next slide, please. So these are some slides which I have put up just to show that the various trials which are showing the overall survival. So the dacomitinib is showing around 34 to 36 months. Next slide. The FLORA final analysis. Next slide. If you see this, the hazard ratio of 0.799. So Dr. Mohapatra, if I can bring you in at this point, we do talk of overall survival. We talk of a positive hazard ratio. Look at that hazard ratio. It's 0.641 to 0.997 and the p-value of just 0.46. It's just trending to a thing. So how significant do you think this OS is?
The trial actually overall survival was not much, especially in Asian and Asian patients and the PS1 patient. They are more later on PS patients.
Right.
But if you go to the dacomitinib trial, actually they excluded more of a brain metastasis patients. They excluded the more patients were good PS actually in dacomitinib trial.
Okay.
So
fair enough. Yeah. So Dr. Ratnam, are you convinced or are you satisfied with this OS? Because you're getting a PFS advantage of 18 months, which is great. But your OS is ultimately just below 40 months. Are you okay with this to give a first line osimertinib, or what's your practice now?
Hello.
Yeah, Dr. Ratnam, we can hear you.
Yeah. So I think osimertinib.
No. So as we discussed earlier, what I do, I still keep osimertinib for failure because I'm happy with the PFS that I'm getting on my patients and sequencing of therapy.
You're happy with sequencing. Yes, Dr. Navneet, you were saying something.
No, what I'm saying is all said and done, in practical situations, we don't end up using osimertinib just because of the cost. but
Right.
and most of my patients end up getting first or second generation TKIs. I mean, more afatinib is certainly something which you could use upfront in exon 19 DELs and then follow up with osimertinib. But then from practical point of view, most of our patients, at least in my center, and maybe even AIMS from what I know from Prabhat, we all end up giving gefitinib as the commonest type of.
Right. Okay. Would you add the gefitinib with the chemo then in that case? Because you're getting a better PFS, though the toxicity is higher.
So that again, that is usually a discussion which I make with the patients when they come. A lot of things are determined by the geographical area from which the patient stays, whether they are willing to come
logistics
back
basically
this thing, and the toxicity definitely.
Fair enough. All right, next slide please. So again, this reason why I'm bringing all of these again is for the combination. Next slide. When we look at the results in the combination, especially the Chinese study which we had gotten, and also these Japanese study and the bevacizumab erlotinib study, all of these things, the median PFS is better. The median survival is actually going up to almost 45 to 46 months. So that is something which is a combination we use. Dr. Bharat, what's your take on these VEGF TKI combinations? Are you practicing it?
Yeah, so Vamshi, it is very important to know to have a good PFS apart from the osimertinib in the first line, because as I already mentioned, there is no data after osimertinib. So it's a good combination to use either chemo or doublet with gefitinib as per the TMS data and the Japanese study, or to go with the VEGF. Now there is good data to
what do you do in practice?
Again, in practice, so in real
world, practice, what do you do? Yes.
So in practice, me and most of the colleagues are doing, because of the cost concern, most of first generation we are using along with the chemotherapy in a fit subset. But for the elderly patient, it's very difficult to know, because in the trial, they have continued pemetrexed with gefitinib in the maintenance. It's not only 4 cycles of chemotherapy. That again is an important point you need to consider. And pemetrexed is
what
not
about
a simple
the VEGFs?
So I have
you
not
can
used,
keep on giving.
Yes, I agree with you. And there is no data coming up ramucirumab, as well as there is a data with the bevacizumab also. And with the generic bevacizumab, now I think most of us will be comfortable because cost will not be that no big issue for this thing.
I think one thing which if I may, one thing which I would like.
Sir. Yeah.
One thing which I would like to say is that gefitinib is the drug which has the highest potential for hepatotoxicity amongst all of these TKIs, and we have often had to switch patients on gefitinib monotherapy to either afatinib, or if they can't afford, even to erlotinib. And so when you combine gefitinib with a pemetrexed based combination, the potential for hepatotoxicity definitely goes up significantly.
Point taken. Next slide, please. So again, this was the data what the pemetrexed plus TKI have shown. Again, the same thing. This is the TMH on one side and the Chinese data on the other side, which says that you are getting good PFS and good, but toxicity, point taken, is important, and we need to continue pemetrexed maintenance, which is not always very simple. So next slide.
Vamshi.
Yes, Bharat.
So it would be very interesting to look at, there are phase 1 or 2 early clinical trials about using only, without platinum pemetrexed VEGF antagonist and lower VEGF inhibitors in the lower doses and TKI. So, there are very early phase. Yeah.
So next year we'll discuss all that, Bharat. So anyway, since you're there on the mic, this question I would like to ask you to answer. Do you really look at the type of EGFR right now? Or are you just taking EGFR exon 19 and L858 as the same bunch? Are you differentiating these two? Dr. Bharat?
I think we should move on. Yeah. We lost him.
Okay, we lost him. Okay. Dr. Navneet, do you change your treatment based on the type of EGFR, L858R versus Del 19?
So
hello? I'm not able to hear you. My bad. Hello?
Bharat, I will message you and you can take the answer then. Bharat, you can answer later. Yes, doctor.
Yes. So I think the place where it really makes a difference is if you're considering afatinib for an exon 19 DEL. For L858Rs, perhaps it doesn't make that much of a difference. And if you're using first or second generation TKIs or osimertinib, again, it's not going to make that much of a difference.
Okay, fair enough. Next slide, please. So the reason I bring this is because both the Lux Lung 3 and 6 showed that the OS in the Del 19 subgroup was much better than that of the L858R. Next slide. The Archer also was conversely showing. It was showing that in the exon 19, the benefit was similar. Next slide. And in the Archer 1050, the exon 21 showed an improvement for the dacometinib. Next slide. Whereas in the Flora, again, you're seeing that osimertinib does better in the exon 19. So this is the reason why I'm just asking this question, that in practice, have we started differentiating? Dr. Ghanshyam, have we started doing this differentiation in practice, or we are just looking at same practice?
So no, so at this moment, so probably 19 and the elite habitat, so we are treating the same. So probably in time to come, we will try to differentiate.
Sure. Dr. Navneet, your practice is the same, or do you think we should start differentiating the two?
Navneet has left probably.
Dr. Navneet?
Yeah.
Yeah. So are you differentiating right now between the two, or are you doing the same one?
No, so I mean, as I said earlier, if you're talking of the exon 19 del versus elevate 5 beta arrest.
Correct.
So not for osimertinib, not for first generation. For afatinib, yes, when it's an exon 19 del, I mean, even it's not just the data. Even in routine clinical practice, what I have seen is that exon 19 dels do tend to do pretty well on afatinib, and the PFS is certainly more than that 13 months which is there in the trials.
Okay, perfect. Great. So next slide. So moving on, we'll just discuss what happened in our patient. So the treatment strategies, I think by and now, everyone is aware. You either use a first generation, go with the T790M positive, go with third generation with the chemo. Next slide. Or you can start off with a second generation, slightly longer PFS, again the same criteria, improve your overall survival. Next slide. Or you can go with a third generation, longer PFS, but you do not have any further chemo options in most of the patients. Yes, we have the MET, we have the other things, but by and large, you end up giving chemo. Next slide. Or you have these options where you give the combinations, then give a third generation, then give a chemo. So we do have all these options. No right answer because we don't get these tested across subgroups. But yes, we need to look at the type of EGFR. We need to look at the patient. We need to talk to them. We need to find out the logistics and then decide on the options. Next slide.
If I may
yes,
interrupt.
Dr. Navneet.
Yes. So when you're using a combination of first generation with either a VEGF inhibitor or chemo, do we know that the T790 incidence on progression is the same as when you give a first or a second generation monotherapy?
I don't think we have the right answer because at least as far as I have seen, none of the trials have talked about it so far. I may be wrong if somebody knows. Yes.
We don't even know that you could use osimertinib post-progression on these combos.
Absolutely. Point taken. So this is my summary that third generation osimertinib probably has a comparable OS benefit at this point. We cannot say it is better. It is expensive. Toxicity and discontinuation are issues. Next slide. The second generation followed by third generation, potentially longer survival with more affordability. Next slide. The TKI chemo is right now exciting in terms of its OS, but side effects are more and we really don't know the right sequence. Next slide. So our patient was started on afatinib. I do happen to be a big fan of afatinib for whatever reason. And I agree with Dr. Navneet that in clinical practice, we are seeing longer PFS than what is shown in the trial, especially for the DEL 19. Patient had a good symptomatic response. PET CT after 3 months showed a partial response. 12 months showed a stable disease. At 18 months, the lung lesion increased from 2.3 to 2.9 centimeter. Mediastinal node slightly increased, but clinically very stable. So Dr. Ghanshyam, at this point, would you change treatment just based on slight resist criteria or do you go with the clinical features as well?
Absolutely, we're not going to change. We have seen this patient will still be good for another few months or so.
Very good.
Before
Dr.
they are
Ratnam?
clinically.
Very good. Dr. Ratnam, what's your take? Would you do a testing for T790 at this point or would you wait till you want to change the drug before you do a T790M? I think we have lost him. Dr. Navneet, what's your practice?
I would do thoracic radiation.
I totally agree with Dr. Bishwas.
So when would you do the testing? Would you do it now or later?
Yeah, I know we are at the threshold, the 18 months you have put the right time, but I think...
So you would wait. Okay, next slide. So in our patient, yes, sir. Please go ahead.
Yes, I would consider thoracic radiation at this point of time if it's not been done. The reason is patient is asymptomatic. You have sort of oligoprogression. You do thoracic radiation. You might be able to achieve again some clinical benefit, and that would give you more time.
agreed with you. We discussed with the patient, he was not convinced, and this American people whom he was talking to were also not convinced. We did do a liquid biopsy at this point, which was negative for all the mutations, so we continued afatinib. Next slide. Now, after continuing afatinib at 24 months, so that is 6 months after the initial point, at this point he had increasing cough, there were the mass increase, there were new lung nodules, he had developed pleural effusion as well. So at this point, I think all of us will agree we'll check for T790M. Next slide. And when we did the T790M in the liquid, again, none of the mutations were detected. So Dr. Ullah's liquid biopsy always does not detect. We went ahead and did a biopsy. And after the biopsy, we found both the exon 19 deletion and a single point T790M mutation was there. So next slide. With T790M positive, we did go ahead with the plan for the osimertinib. So that's how the sequencing goes on. Next slide. Next slide. Next slide. So Dr. Navneet, this is the geotag study which was showing that sequential treatment of afatinib and osimertinib. Next slide. And this showed that if you actually use afatinib followed by osimertinib, around 75% will end up having a T790. And that ways you can actually develop a almost 42 month on only afatinib and osimertinib. How do you look at this strategy? Do you completely agree with it? What's your take on it?
No, so this was not a randomized trial. This was a highly selected group of patients who were enrolled in this, and what you are seeing is basically sort of selection bias in this.
Okay.
So
okay, right, fair enough. Dr. Ghanshyam, what's your take on this? Afatinib followed by osimertinib better than any other drug. Do you agree with this statement, or do you agree that it's kind of a forced presentation?
I started believing in this actually. So afatinib second generation followed by third generation.
Okay, perfect, very good. Dr. Bharat, are you there?
Yeah, I'm here. Sorry, last time, no, it was the network
so
problem.
what about your take?
See,
No
Vamshi,
issues,
in
no
the
issues.
beginning,
What's your take on this?
you started with a very important note that real world, what is happening in the real world. Forget about the trial, what we are doing. So our experience with jaftinib erlotinib is more than 10 years. Our experience with afatinib is slightly near to that. Our experience with osimertinib few years. Okay. So I haven't seen a single patient who is doing excellent with osimertinib putting on 3 years back on osimertinib. None of the patient. And I think everyone must have the same problem. I have patients who have continued beyond 5 years on jaftinib. I have few patients who are nearly 5 years on afatinib. So sequencing is the way forward. You just can't rely on the data of only afatinib. So again, I want to give the equal credit to jaftinib and erlotinib too.
Very good. Dr. Ratnam, do you agree with this? In clinical practice, forget the trials. How do we look at our patients doing? Are we seeing osimertinib doing as?
Yes, I do agree with the previous speaker. And I think with the generic afatinib coming in last couple of months, I've already started planning this sequence of afatinib followed by osimertinib. I totally agree.
Very good. So this was the geotag, and it showed that you had around 83.9% survival rate at 2 years. Next slide. The study also showed that your time on treatment was longer when you used this for both the deletion 19 subgroup. You had a time of treatment of almost 36 months with this combination. Next slide. So this was a small paper. Again, I'm obviously quoting rather selectively. So this paper was one from the ESMO 2018, which again showed, next slide, that when you used between erlotinib and afatinib, next slide, the survival and the objective response rates was higher when you use the combination of afatinib followed by osimertinib rather than the other way around. Next slide. So this is of course a small study and we cannot really conclude, but I think this is kind of tending to what we also see in our clinical practice. But as Bharat says, we cannot exclude jeftinib and erlotinib. These are old babies, but they are really good babies, if I can put it that way. Next slide. So continuing with the story of our patient. Next slide. Yeah, so our patient started osimertinib 80 mg. After 3 months, he only had a stable disease. He could not really achieve a partial remission. And at 6 months, he had an increased effusion with an increase in the lung mass. Next slide. So what are the options after EGFR TKI? Dr. Navneet, if I can ask you here, bring you in here, what would be your option after these two TKIs?
So I think it will depend upon how much the patient is willing for further testing and evaluation for therapy. So poor patient, I mean, not too much resources, I would just shift to chemo. And if somebody is
Okay.
willing, you could even do a re-biopsy by doing a thoracoscopic pleural biopsy or a liquid biopsy NGS, look for alternate mechanisms of resistance, and offer appropriate targeted therapy if applicable. It boils down to what the patient is.
So, Amshi,
yes, Bharat.
When you exhaust 2 lines of TKI, I think everyone must be seeing this kind of scenario. The failure is mostly in the brain, majority of the time for the mutation positive patients.
Fair enough.
Yeah.
Fair enough.
So I think
So
by
you are talking
using the
about
other modalities like
treatment of the brain and
yeah. So
fair enough.
at some
Understood.
point of time,
That's perfectly
on
fine.
Progression, yeah. So brain targeted therapy.
Understood. What about systemic progression? Systemic progression, what would you do?
So then again, so doing a biopsy is very important. Sometimes there are other kind of cell transformation or other
What about
mutations.
the IO-based treatments?
So
what
yes,
about IO
that is we always
have
always had an anxiety of using immunotherapy in mutation positive because because of the toxicity. But now the data is coming up. If you exhaust all the lines of therapy, so you definitely can go with the combination of VEGF and immunotherapy. And
perfect. So basically, we do have options. We cannot give up if the patient remains willing. Next slide. So in our patient, we got a foundation testing done, and that showed a EGFR exon 19 only, loss of T790M, which is bad. The other mutations only showed some make and missed and I don't know what all. No real targets. TMB low, MSI stable. Next slide. TPS 80%. So being what we, like all our panelists said, we started on the ABCP, that is the Atezo-Bev combination with chemotherapy. It was started in November 2018. After 4 cycles, there was a complete resolution of effusion. Patient was much better. Continued Atezo plus Bev for 9 additional cycles. So 10-month PFS we get here. Then he presented with abdominal pain, and PET scan showed a lot of omental disease. Unusual presentations. We were not sure if it was a TB or something. We got a laparoscopic biopsy done, and that confirmed that it was an adenocarcinoma. So at this point, 4th line onwards, what's our take? Dr. Navneet, what would you start at this point? Patient willing still to go with all treatments?
I would still probably have used pemetrexed up front rather than ABCP because after all said and done, IOs in EGFR and ALK positive, I mean, I'm not a big fan. So, but anyway, you could use ABCP versus PEM carbo or whatever. And here, I think the the PS of the patient is really something which is going to matter, and basically the goals of therapy.
So I guess we are going by the I am brave because that's where the IO has only worked. IO has not worked in other settings. So that's how we went with this patient. Next slide. So again, at this point, we did follow what you are suggesting. We gave pemetrexed single agent, total of 6 cycles. Again, there was a progression. Next slide. So after this point, we have already exhausted 4 lines. At this point, patient was still willing and was willing for another repeat foundation testing. So he repeated the foundation. Now, if you see the T790 has reappeared, exon 19 is still there. MSI has become stable. TMB remains low. So again, continuing lines of chemotherapy is what we would advise. Any takers for repeating a TKI? Dr. Bharat, any data or anything that says we can repeat?
So
would repeat it. What TKI?
So see, this is like 3rd line or 4th line you are talking about.
5th line. 5th line actually.
Yeah, 5th line. And your patient showed T790 in the first progression.
Initially, there was T790M. We gave osimertinib, loss of T790, now reappearance.
Yeah. So then, loss of T790 and then a reappearance. So I think it is fair to give a chance again for the oral TKI.
Osimertinib. Fair enough. I think that's what we could think in practice. Next slide. So like I said, as you can understand by now, this patient is kind of somebody who has a lot of money, who is willing for testing, and who is in constant touch with people from the US. A problem with a lot of us in Hyderabad at least face, anybody rich enough has 10 people sitting in the US who would keep giving us advice. So they did not suggest TKI. So we gave nab-paclitaxel at this point of time for 3 cycles, stopped due to peripheral neuropathy. I gave him a choice of continuing osimertinib versus afatinib. He liked afatinib because he said afatinib worked for 24 months. Osimertinib worked only for 5-6 months, despite it being so costly. So that was his logic. I do not know. I could not disagree with him. So we gave him afatinib as a last ditch. It did not work. Presented with SAIO. Then gave again 1 cycle docetaxel, but continued nab-pacli. Again have now shifted to gem-bevacizumab. So basically, he's using all chemotherapies one by one. At this point, he is using other kind of treatment like oxygen therapy, hyperbaric ozone therapy and all. All of them seem to make him slightly better. but there is a progression. And so he has now wanted to do Garden 360, which is the liquid biopsy. Yes, Dr. Navneet.
So my comment is that once you start having progression, and the greater the progression, for example, progression on second line, progression third line, the role of tissue biopsy sort of reduces and the role of liquid biopsy increases because you have more and more heterogeneity and more spillovers, I guess. That's my point of view.
Fair enough. I think we really don't know the correct answer, but like I said, we did do a 360 Garden now. I know the data is mostly the first line, but we did it at this point, and I'm hoping for some mutation that I can target. Next slide. So just to summarize this patient, we had a patient with exon 90 in EGFR, afatinib 24 months, osimertinib 6 months, ABCP of 10 months. So around 36-month chemo-free so far, further chemotherapy for 10 months, and now OS is around 51 months and counting. So to summarize, basically, we do need to consider sequencing, and that is probably what will give us the maximum survival. And that's the real aim of what we should do. We should not give up on a patient also is what I feel. As long as patient is willing, as long as they have a good performance status, sequencing is really the way to go forward. And that would be my take on this subject. So thanks again to all my panel for a lovely discussion, and over to the organizers.
Thank you very much. Thank you very much, Vamsi, and all the panelists. This was exceedingly useful and in-depth. We now move on to the next one. Over to Kashish.
Thank you so much, sir. Our next moderator is Dr. Shevanti Limai, medical oncologist from Mumbai. Our panelists are Dr. Ashish Singh, medical oncologist from Vellore, Dr. Ajay Bapna, medical oncologist from Jaipur, Dr. M.V. Chandrakant, medical oncologist from Kolkata. And ma'am, please note Dr. Anita Ramesh will join us soon, who's a medical oncologist from Chennai. Over to you, ma'am.
Thank you. Thank you so much. And thank you, Purvish and Kavina Creations for inviting me to moderate this session. And
good morning to you all.
That was a great session by Vamsi. Thoroughly enjoyed. And the head is still reeling from last evening with the Hollywood and the Bollywood discussions with Dr. T. Raja. I bring in more of targeted therapy. And now we are going to discuss about EGFR mutations with a difference. So earlier we used to talk about, so first of all, I'll welcome my panelists for this session and very quickly dive into the nuance of uncommon EGFR mutations. So when we would talk about EGFR mutations earlier, it was basically yes or no. Now it has to be more defined. We just heard Vamsi with all the nuances of how to sequence therapy and which drug to give first and which drug to give later, and the controversies and dialogues keep going on. Now we move forward into the further nuances of EGFR mutation, and to just understand which ones are we dealing with. Next slide, please. So when you look at the uncommon mutations, in general, all of us are now well versed with the presence of uncommon mutations. So I would roughly put it in the category of anything other than exon 19 deletion or exon 21 L858R, as was just discussed by Vamsi. So the chunk of the mutations are these two. The rest that remains, and we'll discuss the nuances, are the uncommon variants. Why are they important? Because they have a large role. So 10 to 15% of tumors harbor uncommon EGFR mutations. Next slide. Ranging from exon 18 to 21. And just to note, there are 594 different types of EGFR mutations that have been reported. So that's a huge number, and for us to really understand which one are we dealing with is very, very critical. A lot of us struggle. Some of us know this better than the others. And I think this is a challenging field. It's still a growing field. And heterogeneity is even more challenging when we get heterogeneous compounds and we get heterogeneous presentation in patients. That's even more challenging. So next slide. So how do we define uncommon EGFR mutations? And, you know, just to start, I'll pick on my panelists. So with A, Dr. Ashish Singh, your thoughts? How do you think of uncommon mutation, EGFR mutation? I mean, now we
I think,
yes, please.
yeah,
I think this topic has gained more relevance because now we have spoiled for choices. And earlier days, it didn't matter because they were comparing your TKI to chemotherapy or other options. And so even the drug companies, when the pharma companies did not bother too much in the earlier days. But now when you see anything which is not Del 19 or Exon 21, they're not even included in the clinical trial. So much so that we have a panel discussion today, but I don't think we have any randomized data to talk about. So at the moment, I mean, I would say anything which doesn't fit into the Del 19 and Exon 21 L858R, I would put, we are going to look at them differently.
Great.
And in that also we have sensitizing mutation, we have resistant mutations, and then sometimes we have more than one mutation. So it's a big basket.
No, Shivanti, I'm Dr. Anita here.
Yes, please, ma'am. Please go
yes,
ahead.
what Dr. Ashish said, I agree with him also. So this is a very undefined question also, uncommon mutation. We do not know. So any mutation which doesn't have a targetable drug is called an uncommon mutation. And we have one drug, afatinib, that's what they say, that it acts on these type of uncommon mutation. But then NGS panel, once you run, it can give you an answer.
So I would like to slightly improvise what Ashish and Dr. Anita said, that now the EGFR mutation, the broad terminology for them are the classical and the uncommon. So the classical will be L858R and the Del 19, and anything other than R can be put in the category of uncommon EGFR mutation.
Yeah, fantastic. So all three with A came forward, and that is great. Next slide, please. I agree with the versions, and basically I also categorize as anything other than 19 and 21. But Bapna said very well that we have to now look at classic and non-classic, only because I think it is becoming much more relevant. If you have a patient that you're categorizing as non-driver mutation and you are offering immunotherapy to that patient as first line in combination or alone, you better know what you're dealing with, because if there is a pathway that could portray resistance to treatment, you have to take a decision call at that time whether to offer that combination or not. So just broadly speaking, this is one of the definitions that has been projected by a team that has been studying this particular group of mutations. So T790M positive patients, again, listed as uncommon. Exon 20 insertion, we know, listed as uncommon. Major uncommon is another bracket where we have these three specific ones. 719, I just remember the numbers, 719, 861, and 768. But there are others that are not represented in here, which also come under this. And then there are compound mutations where you have insertions plus deletions, plus or minus common mutations. So a very, very broad heterogeneous group of mutations that come under this cover, this umbrella. And the nuance is to understand, just like Dr. Ashish Singh said, nuances of each one of these and whether they are targetable or not, and they're sensitizing or not, or resistant mutations, and to understand and then treat your patients. Next slide. So what is the preclinical evidence? Next slide. We know that these mutations will act differently to different TKIs. And if you see this slide, we have L858R, and the deep blue line is osimertinib, the green line is gefitinib, and the turquoise line is afatinib. Just to answer Ullas said, I will understand the different colors. So here are the different colors for you. So the turquoise is what I'm trying to point out here. That there is sensitivity to these drugs in a different way. Every mutation will sensitize differently. If it is a sensitizing mutation, may sensitize differently to different drugs. And the idea is to understand which drug is the most active in this. Next slide. And again, this slide also reiterates the same, that if you have a particular drug and you have laid out all the different mutations, and here we are looking at the major mutations, how each drug is different for the mutations. And if you look at the afatinib activity, it definitely stands out in this group of uncommon EGFR mutations. Next slide. So question for the next group of panelists here. Dr. Chandrakant that I haven't spoken to yet. So what
Yes,
are
ma'am.
your thoughts on different molecules and different uncommon EGFR mutations? Do you
So,
treat them
yeah.
differently?
So they are uncommon because the percentage of patients are less. That doesn't mean that they're not sensitive to targeted therapy. Hence, we have to identify what type of uncommon mutation they are, because they may do as well as the other sensitive part. So if you look into all the uncommon mutations, exon 19 has no uncommon mutation. Whatever uncommon we have is in exon 18, exon 20, and exon 21. So afatinib works in almost all the uncommon mutation except exon 20 insertions. So in exon 20 insertions, we have poziotinib. And if we want to give afatinib in exon 20, we should combine afatinib with cetuximab. So this is all what I could digest from whatever little literature is there.
No, that's great input. Anyone else? We'll go to the next slide and we'll ask the question. We'll continue to ask the question.
Ever since we have availability of data of post-hoc analysis of LuxLung 236, we have developed a new insight, which kind of molecule should be used in which kind of uncommon mutation. So as Dr. Chandramohan said that exon 20 insertion, but the de novo T790M is equally bad.
Yes.
So we have a targeted drug now.
Dr. Shivanti.
Yes, please.
Dr. Shivanti. Yeah. So yes, uncommon mutation, we are running short of drugs. Yes, afatinib is applicable, but many of the times when afatinib is not possible, I use chemotherapy in these cases, systemic chemo. But yes, afatinib in the reimbursable sector, almost around 10 to 12 cases I have on uncommon mutations, which we have used.
Excellent, excellent point. Anyone else? Dr. Ashish Singh, you have anything to add in this? How do you think of your uncommon mutations drug to use?
Yeah, ma'am. Initially we all had gefitinib and erlotinib, and when these drugs came, we didn't even knew about EGFR mutation. It was only later in the IPAS we discovered. And then when you have this osimertinib coming in, the predominant reason for developing osimertinib was against T790M. And they kept it as specific as possible to reduce toxicity, because we all struggled with toxicity with afatinib and decomitinib. So for me, actually, if you look at the spectrum, the only two drugs which can have a possibility of working pan across other EGFR mutations could be either afatinib or decomitinib. Right. And both of them seems to be irreversible inhibitor rather than reversible ones. Decomitinib again appears to be more toxic, and we don't have that wealth of data what we have with afatinib. So again, Dr. Anita pointed out this, giving chemotherapy. I think what we can discuss is the usual dilemma. Just because you have an uncommon mutation, do you start with TKI just because it's a mutation, or still chemotherapy maybe as good or even has a role? And then the whole thing about sequencing. We talk about sequencing in exon 19 and 21. What about an uncommon mutation? So that's my
so lots of nuances to cover when we talk about uncommon, because one of the things that comes across is that a routine thought of a generic TKI may or may not work. And so in understanding which particular mutation we are dealing with, this slide actually just describes the sensitivity of the different drugs in different uncommon mutations. So one of the things that was mentioned, that we don't see uncommon mutations defined in exon 19, and that is correct. We have the exon 19s are mostly already categorized. They don't come under uncommon variants. When we look at exon 18, we look at exon 20 and 21, we have this layout of uncommon mutations, wherein when we look at osimertinib and sensitivity, and you look at exon 20, you have the sensitivity pan exon 20. So that is one of the observations that we need to take home. The other observation to take home is obviously afatinib. And if you look at exon 18 and uncommon mutations, most of it is blue, which tells me that this is an active drug for the major uncommon mutation variants. When we look at exon 20, afatinib is not that blue, which you have all different colors, And that's where the question of appropriate activity and adequate coverage comes in. Again, you have exon 21 and quite a heterogeneous coverage with both osimertinib and afatinib. And so we know that L858R, we have the activity with both the drugs, but we still need specific trials. And well said in the last session, there aren't any specific trials running only for L858R, or even stratifying that prospectively, not that I know of, where you are studying the activity of a new drug in a specific way for this particular mutation. But I'm sure there'll be much more data to come in forward. What we need to take away from this particular discussion and this slide is that there is variable sensitivity to different drugs. And when we think of a particular exon mutation, we have to really factor in which drug will be working for this mutation or that. Next slide. So I think I've already asked the question of which drug. Next slide. Now, just to go over some of the data that was already mentioned. So we have the largest data from the Lux Lung studies. We have the Lux Lung 2, which was a phase 2, we have the Lux Lung 3, which is a phase 3, and Lux Lung 6, which is a phase 3 as well. And the representation of the uncommon mutations in the phase 2 study was 23 patients, then 37 patients and 40 patients. So a limited patient cohort. When we talk about routine EGFR, we have thousands of patients database now. But for uncommon mutations, we have a restricted database, much more nuanced, very critical to understand the differences better. And a database here helps because of what Dr. Ashish Singh had said earlier, that if there is a particular mutation, you have to try and understand whether this is a sensitizing or a resistant mutation, or even for a sensitizing mutation, what is the data for activity of a particular drug for that mutation, because it's so heterogeneous. Next slide. So this is the, from these trials, the pool data. So you have mutations in the group 1, where you had point mutations or duplication in exon 18 to 21. In the group 2, you have de novo T790M. So T790M is across the patients. And then you have deletion 19, you have compound with L858R, 719, and L858R plus 719. And then you have the exon 20s. So 3 groups were made. Next slide. And here's the waterfall plot. So one thing that I observe here is that the exon 20 insertions are all grouped together. They have not described the specific kinds of exon 20 insertions. Yes. And that is also very critical because we know that all exon 20 insertions are not the same. So I see you nodding your head, sir. Bhapna sir, any comments on this waterfall plot? What would you think? Would this...
From this waterfall plot, we can easily find out that the most sensitive amongst the uncommon EGFR mutation will be the H768I. So there will be the post-hoc analysis have shown that they show 100% response rate.
Right, sir.
Yeah,
that's a great observation.
Followed by the G719X, which has 78% response rate.
Correct. Excellent. So yes, the group 1 was of the highest responders. The group 2 was next, and group 3, well, occasional responses you see a high in
8 to 9% in group 3.
Right, sir. But this was really not that well defined, and we know that for this particular group of patients, we have.
I mean, somebody said of using chemotherapy, but chemotherapy has got response rate of only 22% in comparison to the combining 71% with the afatinib. So chemo is, I don't think, is the real answer.
So
response rates are very low.
Right. So now there has to be sort of a dissecting mechanism. One has to try and understand which particular uncommon mutation we are dealing with. Very importantly, if we have the major uncommon mutations, then in comparison to the TKIs, the response from chemotherapy is actually quite limited.
Yeah.
And so if you have access to a TKI, and especially if afatinib is a possibility, even osimertinib is a possibility, then one would want to offer that and keep the chemotherapy for failures. But if you have an exon 20, then you may think of offering chemotherapy if you don't have other options.
So the solution for the 50% of uncommon EGFR mutation is known to us, that is afatinib. The problem is lying with the rest 5%, which has de novo 790M and the exon 20 insertion. So
excellent, excellent. Yes.
Yeah.
So agree with the thoughts. Next slide. Yeah, so just as Sir already outlined, in terms of responses, 719, 768, 861. So the point.
This is what I was mentioning.
Yeah, so these are highly responsive to afatinib, and one has to remember that when thinking of offering the next line of therapy to the patient. Very critical. This slide remains very critical when we are deciding which agent to use. Next slide. So question comes in, how do you choose between afatinib and osimertinib? I'll scoot over to the next slide and then come back to the panel. So we talked about the responses. Here again, the responses outlined. We know that in the group 2, the responses are lesser, and in group 3, again, the responses are lesser. So we talk about the disease control rate, and the disease control rate, if you see, is the highest in the group 1, which we already discussed. The overall response rates were very high, and this is with afatinib. Next slide. And this is with osimertinib. When they outline the major uncommon mutations, these are the responses seen with osimertinib. So question for Dr. Chandrakant, any thoughts on whether you would use this drug versus that?
So afatinib is a second generation. It's a pan ERBB blocker, whereas osimertinib is a third generation, and it is very specific to 19, 21, and 20. So if I have 20 and 21 on those areas, I would choose osimertinib because side effect profile is better. If I have a exon 18, even though we have some data that osimertinib does work, I would be tending to choose afatinib over osimertinib if it's exon 18. So this is what logically I can conclude, even though there is no evidence.
Great. Great. I never thought of it that way. Thank you. Dr. Anita, any thoughts on this?
Hello?
Yes, ma'am. I can hear you.
Yeah, okay. Again, yes. See, if it is a T790 mutation, yes, osimertinib will be my drug of choice. But again, how others have said, any uncommon mutation, I do regularly use afatinib. The osimertinib use is much less for me.
Yeah, and Dr. Ashish Singh?
Yeah, ma'am, I think I'll agree with what Chandrakant said. At the moment, I mean, this is a Korean trial, which I think just in 2020 Jan. Before this, there was no data, but now it seems like even osimertinib can be an option, especially in the exon 20 space. And they're reporting a PF survival of about 8 months, 15 months, and 12 months, depending on the mutation you've got. So, I mean, at the moment, it's difficult to choose. Maybe we can choose as based on the exon or the toxicity profile.
Great thoughts. Thank you. Next slide. Yeah, we'll go ahead. So we'll talk about some real world evidence. And, we talked about the second generation and the third generation. Does first generation have any role in this? So next slide. Because a large part of our country will still see first generation, if at all they get tested, they will still see first generation. So first generation TKIs really limited benefit with in uncommon mutation situation. And that's where I think Dr. Anita Ramesh's point really comes in meaningfully, because a large proportion of our patients in the country are still not getting tested. If they do get tested, they still may not have access to drugs like afatinib and osimertinib. And so what is the reality? How are we going to deal with that? Are we going to offer first generation TKIs? And so this slide is actually illustrative. I think it is important for us to understand that first generation TKIs actually for major uncommon mutations and exon 20 insertions really don't do anything much. Dr. Bapna sir, any experience with first generation
No, not
TKI in
really.
this
No,
concept?
no, I don't.
Anyone else who has used it or has found a patient who came on this?
No, we haven't seen any great responses.
Okay, yes. So I agree with that as well. Actually, when there is a progressor you know, they're known to be classic EGFR negative, and you then happen to test them and they are found to have an uncommon mutation, you realize that the reason for their progression may have been this, because the uncommon mutations are poor performers in general. They are the mischief makers. Next slide, please. So if we don't have access to the couple of drugs that we discussed, the second generation TKIs and the third generation TKIs, then we have to think of really chemotherapy, because the first generation TKIs don't do much. So afatinib for the treatment of NSCLC real life experience was published, a database of 693 patients. Next slide. Last author, Edward Kim. Kim is a friend. So 708 cases were taken, 693 cases were finally studied, out of which 315 were TKI naive and 378 were already pre-treated. Next slide. So what major uncommon mutations do you see in your clinical practice? I think we have already addressed that. We'll just go ahead with the next couple of slides. So here in this particular study where we had 693 patients, the largest population was major uncommon mutation. And then there was around 25% of exon 20 insertion. The other, which included you know, compound mutations as well as compound mutations separately, 12% and 10%. Compound with major was a large chunk, which was 65%. Next slide. And T790M was 11%. So before I go to compound mutations, do you see equally high numbers of exon 20 insertions in your practice, 25%?
No, it's quite rare. Yeah, 1 to 2% of all uncommon EGFR mutations.
Sure.
Yeah.
I think ma'am, it also has to. Yeah, it also has to do with how you do your test. If you're going to do a specific PCR, then we may not be picking up all these uncommon mutations. NGS panels would pick up more. Yeah. So.
Actually, the question was slightly different. It was actually that amongst the uncommon mutations is EGFR exon 20 insertion a common mutation. So I may say that it is common. In Dr. Chandrakant, your thoughts? Do you see it often?
So usually the exon 20, not insertions, do not coexist. That S786I usually coexists with other sensitive mutations, and compound mutations does better than individual resistant mutations. This is what I have read. We did have a patient with a exon 18 mutation coexisting with exon 20 insertion. So in this patient, we did give afatinib, but did slightly well for 4 months. So this is what I know about it.
Sure.
So Dr. Sevanti, what is your take on for the Japanese data which showed that they are, some of them are quite sensitive to the IO, especially exon 20 insertion?
That's a very important point.
Yeah, in comparison to the common EGFR mutation, there was a huge difference of 200 days.
Correct.
In the progression-free survival when we use the IO.
Right, sir. So I think there is some data emerging that uncommon mutations actually may have a high PD-L1.
Especially exon 20 insertion.
Yes, sir. So especially exon 20 also has a variable heterogeneous picture. Some of them actually may have a high PD-L1 and a high TMB. And that's where they may end up responding to IO more than the routine. But that has to be studied. There are ongoing 2 trials right now that are looking specifically at this, specifically at the biology. but totally well said about the Japanese study. There are some conflicting results that need to be validated in the future studies, and those angles are being looked at by the thought leaders. So coming back to the compound mutations, I'll just go to the next slide. So there are compound mutations, and afatinib was found to be active in compound mutations as well. Next slide. Yep. Next slide. We'll go to the next slide again. Yeah. So when we look at the coverage, it's 16.6 months for the duration of response for compound mutations. So a lot of us will have compound mutations in our practice, and we know that there is a drug that can be offered for that as well. The other point that I would like to make is all compound mutations are not the same. If you look at T790M plus L858R, there's a longer PFS and OS than T790M de novo with exon 19. So each compound mutation has to be studied properly, and that's where it is important to go to a database. Next slide. So coming to exon 20, we had an elegant discussion by Dr. T. Raja yesterday. Next slide. So we have
for exon 20, we have a new kid on the blog, amivantamab.
Yes, sir. So
yeah,
yes, absolutely. So we see that afatinib is active as well. We see that there is exon 20 activity here. Duration of response in this cohort was 11.9 months. Next slide. There's a whole host of drugs that has come through. This slide is actually dated because it doesn't have the J&J drug that sir is mentioning right now. Next slide. But this is the new kid on the block
yeah.
that we have. It's from a tweet from just
I guess right
4 hours ago.
Yeah.
So I included that in the morning slide.
Oh,
and
very
yes,
nice.
So we have the J&J drug now.
Yeah,
J&J. But long way to go for exon 20, I still feel, but higher responses with the Takeda drug and the J&J.
So I know
drug.
your mind.
Yes, sir. Now you have understood. Next slide. Next slide, please. So this is the hallmark, and this is my last slide. I want to leave you with this. Don't do a guesswork for all my panelists. This is a message that I learned from them as well, that each of these uncommon mutations are different. We have to really understand them well. And this is the database, which has currently, as of today, it has 830 patients in the database of uncommon EGFR mutations. I think that's a very low number. I think we should all try and contribute to the database to be able to get the exact results. And last slide I go to and I leave. Please, just one last slide. Yes, so that's my bottom line. Yeah. So you have uncommon mutations, you have response rates laid out, you have afatinib, you have osimertinib with slightly lesser response, and you have the first generation TKIs. So for me, if you have exon 19 and 21, we know the answers. For uncommon mutations, it is afatinib more. Next is osimertinib. If exon 20, osimertinib, and then many, many more drugs that were already discussed. And so thank you all the panelists, and thank you, sir, for having me here to do the moderation. It has been a pleasure.
Thank you to you also for conducting it so nicely.
Thank you, sir.
Absolutely. I've been part of several panel discussions on uncommon mutations, but this really takes the cake. And I salute
you, sir.
70 and all the panelists for doing such a fantastic job.
Thank you, sir.
Thank you, sir.
Over to Kashish for the next session.
Thank you so much, sir. Thank you, ma'am. Over to the debate. Our first debater is Dr. Arvind Krishnamurthy, surgical oncologist from Chennai. Over to you, sir. So you'll have to unmute your mic.
Good afternoon to all. I would like to thank Dr. Parikh for the opportunity and for a very focused talk for the debate. Stage 3 NSCLC is a very heterogeneous group. Overall, we have around a 20 to 30% cure rates for these patients. The topic is plagued because we don't really have robust randomized controlled trials to guide our practice. And as a result of it, the accepted treatment plans in the real world vary dramatically across centers, right? Next slide, please. In clinical practice, it is very important to differentiate the N2 disease into several buckets like this: A1, A2, A3, and A4. The topic of today is including A3, that is a single station or multiple station N2 disease recognized preoperatively. And we know that even in a single or multiple station, as in A3, the prognosis really varies between a 5-year survival of a 15% in a multiple station versus a single station. The other thing is about bulky or fixed multi-station N2 disease, and we know that these are candidates for definitive chemotherapy and radiation and not for surgery. Slide. And how bulky is bulky? In fact, we don't really have much evidence to state what is bulky, but a majority of the trials and majority of the surgeons in clinical practice would define bulky as anything which is less than 3 centimeters, and this is the case in question that we have today. Slide. The guidelines would currently say that the category 1 recommendation, NCC and many other guidelines would say that it is a concurrent chemotherapy and radiation therapy followed by durvalumab. But there is no debate if we sort of just blindly follow the guidelines. What I would request everybody is to read between the lines. What I would as a surgeon say that there is one of the acceptable options. Induction chemotherapy followed by surgery is also an option, especially in the case in question, which is a single station non-bulky N2 disease, right? The arguments that have been put forward, in fact, we don't really have much robust data comparing definitive CTRT versus induction treatment, but we have data comparing induction followed by either surgery or radiation therapy, and they say that surgery is definitely not proven to be clearly superior. Of course, there is a subset analysis that shows surgery favoring in a certain subgroup of patients. Of course, that is also being debated. There are also concerns raised because of the increasing morbidity and mortality which is there in the surgical arm. The major flaws of these 7 odd trials that are there and elegantly picked up in the meta-analysis by Purvish et al. In 2017. In fact, none of these trials we had uniform PET-CT scans. We have lesser R0 resections being done in the group. The increased surgical mortality was there, especially in the pneumonectomy arm, and a 26% mortality rate in pneumonectomies post-induction therapies is something that is clearly unacceptable. So the meta-analysis actually says that the induction therapy followed by definitive resection or CTRT, there's one of the, clearly surgery is definitely one of the options. Slide. There are valid concerns about CTRT as well. The 5-year survival remains poor, and a third of the patients will actually relapse at the local site. And this is the reason why we should consider incorporating surgery in some of these patients. Slide. The real world evidence is for incorporation of durvalumab after definitive CTRT. That is the level 1 evidence. But what we find in real world practice is none of us are able, at least in our setting, is able to offer some of these patients durvalumab. So the argument that I put forward is, why not incorporate surgery at least in a third of the patients who fail in a local regional site following definitive CTRT? Why not incorporate surgery rather than not giving these patients durvalumab per se, right? Definitely there are more recent studies, and I would like to draw your attention to some of these recent studies by Charu Agrawal's group, which says that incorporation of lobectomy post definitive CTRT, you have say that the incorporation of surgery, you have almost a 30-month advantage. Slide. So the safety analysis have also been addressed in about 30,000 patients. They found that lobectomies was acceptable, and only in certain pneumonectomies there was a much higher mortality rate. But otherwise, even in this group, there was only about a 3.4% mortality rate versus a 0.8% with the bimodality group. Slide. I will conclude in just 2 slides. So the focus is now shifting back to surgery. What I would say is we would require a better patient selection, also definitive surgical expertise. Slide. So in a better surgical expertise, we would require surgeons who are familiar with lymph node mapping. They have to do proper mediastinal staging, proper
Can you
bronchial.
conclude, Arvind, please?
Yeah, sure, sir. And more than 10 lobectomies per year. Slide. Can you come to the last slide, Kashish? Can you just run through it? So I said the option for these patients would be, as I said, the options for our patient would be, especially if there's a single station, non-bulky N2, I would say that there is a strong consideration for the incorporation of surgery in these patients. These patients are a very heterogeneous group of patients. We need to individualize their treatments in a multidisciplinary forum. I agree that there are more randomized controls trials that are necessary. This is a work in progress, and of course, with the new focus on targeted and immunotherapies, I think there are something that is definitely will change in the near future. But for the case in question, I would say that there's a strong consideration for the incorporation of surgery in some of these patients. Thank you.
Thank you very much.
Thank you so much, sir.
Yeah, go ahead.
Thank you so much, sir. Our next debater is Dr. Nitesh Rohatgi, medical oncologist from New Delhi. Over to you, sir.
Thank you very much, Dr. Parikh. Always, it's great to be on this meeting. I'm going to very quickly fly through my slides. I was hoping Arvind would show a lot of data, so I fly through it. But anyway, we'll go ahead. Next slide, please. So, okay, I think we'll have to go back to my previous slide. Okay, so I think these are the key questions. Question one, what does the patient want? And clearly nobody wants surgery. Question two, what do patients really want? They want to live longer and better, PFS and OS. Question three, what can we do about that? Let's see. And question four, what is really N2? Next slide, please. And as Arvind has already said, next slide, please. This is basically a mixture of disease, a lot of which is locally advanced disease. Next slide, please. Next slide. And he spoke about this as well. So what is N2? It's a harbinger of metastatic and advanced disease. I think we all have to accept that. Then why the surgery is so vital when we do not consider it in other locally advanced disease? Because to my understanding, it's a traditional dogma, at which point we really did not have better to offer. Then what happened? Next slide, and you can skip a few slides. A lot of meta-analysis happened, which Arvind just said. You could skip a few more slides, please. Which he said that despite of that, we do not follow them because there were caveats with that. I accept. Next slide, please. But did we listen to that? No. Next slide, please. Next slide. And we had guidelines, and yet the guideline clearly, Arvind showed that too, suggests that category 1 would be to consider chemoradiation. But they were, Arvind raised the question if we should follow that too. Next slide, please. And do we have more data? Next slide, please. And next slide. And I'm trying to show that there is data after data. Next slide, please. That essentially said this graph, which is it means the same. So it does not increase any advantage either in PFS or OS. Next slide, please. And next slide. And next slide. So essentially I'm showing slides after slide and I'm saying next slide more than I'm speaking, because there is a lot of data out there which suggests that actually there is no advantage. And yet there's a guideline which says there's no advantage. There's a meta-analysis which says no advantage. Yet we are not putting rest to this debate, which to my mind should not have been there, because even if it's a single station N2, it is a harbinger and a predictor. And we can ask 100 surgeons in the group, how many true single station subcarinal 2.5 centimeter do they see, where when they finally resect, they find that that was the only site of disease. And I guess the answer will be very few, if any at all. Does the future add to the question? Next slide, please. And that is the Pacific trial. Next slide, please, which clearly demonstrated there was an advantage. And this is an add-on. This is not instead of. Next slide, please. So when Arvind said, next slide, please, when we're talking about 15 to 20 months, when Arvind said Durva costs money, I'm actually talking for even patients who can only afford. It was an add-on therapy, it's not instead of. What should we really do? This is my last slide. Well, first of all, we should look at T carefully, because that's really with the subcarinal node, which will decipher whether this patient is even considered for surgery or not. And of course, I'll go back to Arvind and say, is the patient operable? So the looking at T with N is the most critical step in my mind. Then look at the N carefully, because we know that we mostly tend to radiologically understage these patients. We don't overstage them, we understage them. So when we really have resected some based on upfront surgeries I'm talking about, we've seen more. When we've given chemo and resected, we've still seen more N than it really seems to eye. So I'm very careful and I'm very wary of my N2s because they're often N3s. So I'm saying this again, don't be fooled by a N2, especially if it's more than 2.5 centimeter. Arvind used the 3 centimeter, he could have used 2, he could use 5. And I think Dr. Parikh did a good job by making it 2.5. Thank you, sir. But offer CTRT, explain the prognosis, and actually please consider immunotherapy, and I'm sure it'll get cheaper with time. Thank you very much.
Thank you so much, sir. Now I request Dr. Shyam Agarwal, medical oncologist from New Delhi, to please conclude. Over to you, sir.
Good afternoon, everybody. So I think my job is to sum it up. I think both the speakers have done a very excellent and a decent job. So I think you all know the N2 means ipsilateral mediastinal lymph nodes. Next, please. But as I think Arvind pointed out, it's a heterogeneous group. So it can be bulky, it can be multiple nodes. Next slide, please. So I think these are several stations. So I think it is very important when you are looking at a scan and you are suspecting stage 3 with nodal involvement to do EBUS for some of these stations, 2, 4, 7, 10, 11. And the EUSB can be done, which is the endo ultrasound, to look at these stations. I think mediastinoscopy has virtually become obsolete today. So I think it is very critical to look at these nodes and identify whether they're involved or not, so that you can come to a conclusion as to how best we can treat these patients. Next, please. Next slide. So I think this is what, can I have this? In fact, this will come later also. Maybe I'll talk about this later. Next, please. Yeah, so I think this is to show that patients of chemo and radiation, your RT alone, you see the survival, I think, as Arvind was saying initially, was 15 to 20% at 3 to 5 years. So we have not really gone beyond that with the chemo, radiation, and even for that matter, the surgery slides. Next slide, please. So this is showing you the surgery slides in which actually you include, stage 1 and 2 as well. But when you look at stage 3, so there is hardly any improvement, I mean, you're sticking at 20%. 5-year survival or so, in that range. Next, please. So this is the issue of trimodality versus bimodality. So you do trimodality, but when you do pneumonectomy, then the mortality is high, as Arvind was saying, that if you stick to lobectomy, then the survival and the complication rates are going to be low. So the point is that surgeons are making progress in stage 3 if you're looking at lobectomy alone. So you cannot right away, rule out the role of surgery in these patients, select patients. So next. So, if you look at the ESMO and the NCCN guidelines, so if you look at single station N2, I mean, you have all these 3 modalities available. You look at NCCN, this is a little old slide, where you have durvalumab already, but then, people are treating with CTRT, surgery, induction chemo, followed by surgery. So, all these options are there. Next, please. I think I'll skip this slide and go to the next one. So now this is what I think Dr. Arvind was referring to, that the N2 is actually a mixed bag. So if you have, a single station N2, so these are patients which are potentially resectable. I think especially if you have non-bulky disease. So this is which can be defined as less than 3 or 2.5 centimeter. So I think surgery with, followed by, say, for example, adjuvant chemotherapy in a single station non-bulky disease perhaps can deliver same results as you are seeing with CTRT followed by Durva. So I think that is where perhaps a randomized trial, if possible, should be done to see if we can exclude, Durva and subject these patients to surgery and chemotherapy. So patients, of course, who have bulky disease, or patients, for example, who have potentially resectable or, unresectable, where you have Pancoast tumor and so on, there the role of induction chemo followed by surgery
may be there. So it's actually a mixed bag. Next slide, maybe, which is the last slide. I think this slide has already been shown. Next, please. So you see, so the first time in stage 3, you are touching a 5-year survival of something like 50% or more. So it wasn't seen before, as I showed you. You dissect the data out. In stage 3, it's only 20% with chemo and surgery, or chemo, unless you do chemo RT surgery. So which becomes a pretty difficult exercise for patients. Next, please. So that will be my take for stage 3. If you have bulky disease, so which is considered inoperable, CT-RT Durva, inoperable multi-station mediastinal nodes, CT-RT Durva. If you have a centrally located node, if it's considered unresectable, again CT-RT Durva. But if somebody has a minimal N2 or a single station disease, surgery with adjuvant chemotherapy. For T4, N1, induction chemo, then surgery. And if you have N3, then of course surgery is absolutely out, and CT-RT Durva. So I think with this, I close here, and maybe there are questions we can take. Thank you very much.
Can I make a comment? Dr. Shyam Agarwal, can I comment? So all I was trying to say is that subcarinal single station N2 is not the same as ipsilateral single agent N2. I think it increases the chance that we are actually dealing with N3.
Yeah, Nitesh, I agree. I let Arvind also to respond to this, but my slide as per centrally located N2 says CT-RT Durva. So Arvind, please.
No, I agree with Dr. Shyam Agarwal's comment, sir, that you have to sort of do the mediastinal staging accurately in these patients. You determine if it's a single station N2 based on a good mediastinal staging, and only then take it up from there.
Thank you very much, Shyam, Arvind, and Nitesh. We can now move on to the radio diagnosis component of today's webinar. Over to Kashish, please.
Thank you so much, sir. Our next speaker is Dr. Amit Janu, radiologist from Mumbai. Over to you, sir.
Good afternoon, everyone. And thanks for the Purvish Parikh sir for giving an opportunity to talk about this interesting topic. I'm discussing the progressive disease versus COVID-19. We know that it is a most researched topic. Next slide, please. The thing is that there is a significant amount of fear that has been induced by the radiological societies across the world when whether we have to do the scans in that period of time because of issues of the decontamination, sanitations, and the AC ducting and all those things. So we have taken the precautions, and we have gone ahead with that. Next slide. So the thing is that it has been never included as a part of screening or a diagnosis of COVID-19. And most of the guidelines don't recommend it because they think that most of the viral pneumonias or other non-viral etiologies can mix up and can give a similar picture. So the Fleshner Society have come up with certain glossary of the terms that has to be included by nominating COVID-19, and then the Radiological Society has amended these findings, and then the Dutch system has come up with the CORAD system. That is the system how they classify the CORAD related findings. So the thing is that even though it is not a part of diagnosis, but not a part of screening, but it can help in the severity of the assessment. Taking out the alternative diagnosis can help in prognostication and triaging the patients. I will talk about the data that we have done in the last slide of this PPT. The thing is that CT is extremely sensitive as compared to the X-rays, and 50% of the ground, because these present with the ground glass opacities, the findings can be missed on the X-rays. Next slide, please. So we have various shades of gray across in the CT, the nodules and the masses that we are very well versed with when we are dealing with the medical oncology. The thing is that the ground glass opacities, we are not used to this. And this is how the most of the COVID will present. So if you have a what is ground glass? The thing is that if you have an opacity and you can see it through the lung parenchymal vessels, that is the ground glass, and that is the most common and consistent finding that we see in the COVID-19 patients. The other thing is that there can be, when it becomes worse, it can give rise to collapse and consolidations and organizing pneumonitis and all those conditions. In that condition, we don't see the vascular abnormalities in the scan. So next slide, please. So the various strata has been designed just to give the probability score that how much certainty we are dealing with the COVID-19 findings. Cohort 1 is the negative when we don't see any findings that is related to infection or COVID-19 in that case. And cohort 2 is that the findings that might mimic infection but are not typical for COVID-19. So they are mimicking some other kind of infections, and in that case, it can be another viral pneumonias that we are known of. It can be CMV, it can be PCP, it can be TB. So there are other things that can come into the category. It means we are talking about the alternative diagnosis. Cohort 3, when we have the ground glass densities, they are associated with some findings, but we are not certain whether these ground glass densities can mimic COVID-19, and we call them as an indeterminate category. And you can see these are unilateral densities which might have some solid areas, they are in periphery, they are certain patchy, they are sometimes well defined and round. So the category will remain indeterminate in this case. The fourth thing is that when you have ground glass densities which are multifocal and patchy, some are centrilobular, some are pleural, and they will increase the likelihood of the COVID-19. The thing that the category 5 that is very classical in the typical finding, when you see the crazy paving, I don't have the cursor, but you can have these findings when there is a ground glass density and then there is an interlobular septal thickening, there is an organizing pneumonitis sign, there is an inverse halo. All those conditions, they are very, very classical, and they will seen most consistently. And when you do the testing, most of them will turn out positive. The 6 is that the patient has already known RT-PCR positive cases, and when you do the sample, when you do the CT, these are the findings. Whatever the findings you will see, they are consistent with the cohort 6. Next slide, please. So this is the run-of-the-mill case. Actually, we will see this is the last slide. The patient is present with the last slide. Metastatic adenocarcinoma with increased dyspnea and SQ2 that is falling around 90%. The patient has extensive visits and crepitations. So in this condition, there is a certain ground glass density that is present. But if you see the previous scans, the primary has been consistently rising. The 2 scans that has been done outside, and you can see that there is a significant amount, and there is a development of the pleural effusion. So pleural effusion, we don't see consistently in case of COVID-19 findings. We don't see solid nodular areas, and we don't see the lymph nodes. So these are the negative factors that will delineate, and then we have the previous scans with us, and then we can tell whether this is a progressive disease or not. So we need a comparative scan for that. So this is a classical run-of-the-mill case, and it doesn't require a radiologist to see through these kind of cases. Next slide, please. So the thing is that are we aware of the various responses? Yes, most medical oncologists, they know their scans better, but are the radiologists aware of the responses? What kind of therapy the patient has been received? So whether the patient has received a routine chemotherapy or a targeted therapy or an immunotherapy. And in this patient, if you see after this is the first slide, and after that the patient has was on nivolumab and developed breathlessness and hypoxia. In view of the same site, increased infiltration and consolidation in the previously existing areas, the possibility of nivolumab-induced pneumonitis was made, and subsequently you see there is a significant reduction post-steroids. So this is an unconfirmed progressive disease that can be confirmed on the subsequent scan that is done after 4 or 6 weeks of steroid therapy. So if there is a change like pneumonitis, there is a ground glass, there is a local infiltration. In case of immunotherapy, consider one of the possibility that it can be unconfirmed progressive until unless it is an equivocal progression, like there are some other sites which are having solid nodular areas or other areas where there is a metastatic that is coming up. So until unless it is a equivocally confirmed case, it should be treated as an unconfirmed progressive disease. It should be started with a steroid or some other kind of medication after consulting with you, and then subsequently this scan has to be imaged. So in this case, there is a significant improvement. Next slide, please. The other thing is that how the multimodality imaging, how the multimodality treatment affects the imaging. In this case, It is an metastatic CA lung, received paclitaxel and palliative RT for the hemoptysis. And then you can see there are certain areas which are sharply marginated ground glass, and then there is a dilated beaded bronchi that you can see in the upper lobe. At this time, there was a confusion whether this patient is having something or not. But after this next scan has been done, and you can see there is a nodularity that is coming up, there is a convexity that is coming up, the bronchi are all filled up with the mass densities, and this will indicate that there is a same site progression. The thing is that what everybody sees now, so most of the eyes now have attuned to the ground glass densities. People might miss nodules, but they are not missing the ground glass densities, and they are very fond of it, reporting and labeling it as a most likely related to the COVID-19 findings. So these are various spectrum of ground glass opacities that we can see in the COVID-19 patients. Next slide, please. This is how the temporal changes that can occur in the COVID-19 when you are doing an imaging. So the first slide, when it is between the onset of the symptoms, the time that you can see the findings is just in pure ground glass density. There might be an enlarged vessel in those ground glass densities. So that is the starting time. Subsequently, if it is progress and the symptoms become worse, you can see the crazy paving pattern and the consolidation. When the patient started improving, you might see a response that, like the lower sections, that shows there is a complete response. But sometimes these patients can develop fibrosis. And at the time when you do, the patient might have improved a little bit, but some patient will have consistent fibrosis. Next slide, please. So you can see this patient, which has been positive. It was admitted to our isolation ward, and the symptoms are not reducing. The swab has become negative, and the patient suddenly started developing and deteriorating. The D-dimers were done suspecting as a probable cause of pulmonary thromboembolism, and the D-dimers were elevated. The scan sent for pulmonary angiography, and when we did the imaging, we didn't found any significant thrombus in the major vessels. We cannot comment upon the minor vessels because there was a lot of fibrosis for that. And actually, you can see there is a dilated bleeding kind of appearance that is happening here. So some patients, this patient has received lung bath for osteogenic sarcoma mets, and this is the picture. The COVID might have incited a significant amount of lung destruction, and that is how the presentation is that. So this is the sequelae of COVID-19 that is we are worried about, and so that is the care we are talking about. That, and eventually the patient has succumbed. Next slide, please. So the thing is that there are COVID-19 mimics we have seen in when we are following up our cases. So it can be related to drug-induced toxicity. We have seen that the patients who are current smokers, they are continuing still on the smoking. They might give rise to certain ground glass densities, and these are basically respiratory bronchiolitis, induced interstitial lung disease. Patient might have miliary tuberculosis, and if you see the third slide here, actually there is a significant almost ground glass opacity that is present, and when you do a MINIP images, you can find out there is subtle nodular densities, and this will indicate that we are dealing with some alternative diagnosis. The fourth image, actually you can see that this patient
Dr. Amit, are you able to hear us?
And they can really be worrisome, and we should not over investigate these patients and unnecessarily tries these patients. So you can see on the other side that there is an acute exacerbation of IPF. This patient has been done multiple times. It has been COVID has been repeated, but actually the ILD has been exacerbated due to some inciting factor. We don't know what happened to that, but this is the case we can see in the IPFs. So next slide, please. So this is just a brief about the diagnostic performance of the chest CT scans. So we have done a small study. Now the numbers has been increased. So we are now having around 200 patients data. So this is the earlier data that has been analyzed. So it is just the incidental GGOs we have documented for the patients which has scan done for other indications. So these patients are not symptomatic at all, and the scan has been done either it is a response assessment or some preoperative scan assessment. So conditions like that. So we had total 89 patients at that point of time. 25 patients has we have given core at 2 that we have thought about the alternative diagnosis. We are not suspecting COVID. All out of that 25, 16 were tested and all came out to be negative. The remaining 64 patients we classified into cohort 3, cohort 4, and cohort 5. There are 23 cohort patients in which we are indeterminate about whether the COVID was there or not. Out of them, 7 will come positive, 13 were negative, and 1 was inconclusive for COVID. 2 were not tested, and none of the patients were re-swabbed. In the cohort 4, where we are more for COVID, there are 25 patients. 16 of them have came positive on RT-PCR that was done subsequently. 5 were negative on the first swab. 3 were inconclusive on the first swab, and 1 patient was not tested because it was a best supportive care. And then there are 2 patients which are re-swabbed and came positive. So that is the thing. I don't see the last slide actually. Sorry, sir, can you go back? Thank you. So the thing is that in the cohort 5 category, when we are very sure about that we are dealing with COVID-19, 9 well came positive on the first swab, 4 were negative, and 2 were inconclusive. 1 was not tested again. It was a best supportive care, and 3 patients were re-swabbed, and 2 negative which were there and which are been re-swabbed become positive. So that will indicate that not all patients has been re-swabbed which are negative, and it will indicate that there is a still very high certainty that the findings we see on the CT scan are probably because of the COVID-19. Next slide, please. So the take-home point is that we have to locate our abnormality, what kind of abnormality we are seeing, whether it is a nodular area or it is a ground glass area or it is a consolidation. And we should be aware about what kind of treatment the patient has received, whether the patient has received multimodality treatment or the patient, if he is received only palliative kind of treatment, whether it was a routine chemotherapy or it is a targeted treatment or a immunotherapy. And we should be aware of the features that the COVID is have, that is a predominant ground glass density or its associated finding and its mimics. So there are a lot of mimics we see around. Among 90 patients, there are 25 patients in which we have not suspected COVID and none of them came positive. So there are mimics I have discussed. So that is the take-home point. If there is any question, I can take forward.
Amit, thank you very much. This is, I think, a fantastic job that you have done. And I now understand why you took so much time to prepare the slides, because you were trying to pull out the right images. I can also see that you have come to the hospital to do the session. Thank you for taking the time off and making this effort. Now, for the concluding part and moderating the question answers, I hand over to Dr. Vikas Talreja, who Amit, I'm sure you know very well.
Thank you, sir. Thank you for the wonderful presentation. Do we have any other questions?
Sir, I'll just display the slide.
Perfect.
This one.
I think this question has already been answered by Dr. Somashekhar in the chat. He said it was 4%. Vikas, go ahead.
So this question is from Dr. Seventhil M. When did the first medical oncology trial started coming to India, and when in the lung cancer? I think this might be directed to Dr. Advani sir, if he's around, sir.
Sir Advani sir is not there.
Perfect, perfect. So we
I
might.
think my experience was that in 94 and 95 at Tata Hospital, we started getting trials, and Pfizer and Novartis and Eli Lilly were the three companies that first came to us for trials.
Amazing, amazing. It's a entire new generation for us. So for from Dr. Amshi Krishna sir, can all liquid biopsies be deemed equal to the Garden 360? And I think so that has been answered in the chat box also. We don't have. Dr. Purvish sir answered this question in the chat box also. So we might now go to next.
I have a new question.
Yes, Navneet.
Yeah. So this is for Dr. Amit. See, what we are basically seeing in COVID-related scans are GGOs, right? And GGOs in the lung can be caused by a lot of things, right, from drugs to infection. So if you know a patient is COVID positive and you see GGOs, then it's pretty much easy that okay, this could be COVID-related lung abnormalities or radiological abnormalities. The problem is if you do not have any history of COVID disease, the patient has not been tested, and your imaging is sort of not typical, what you were saying, like CORAD score of 2 or 3. So that is the real challenge in trying. So short of doing anything else, a radiology is insufficient. I mean, is there a way you can do something else to make that diagnosis?
So the thing is that actually we are not only seeing the corrects, we are actually our group is there actually that is on the WhatsApp, and that we'll see from the blood parameters. So whether there is a patient is having lymphopenia, there is an abnormality in the lung, what kind of the patient treatment has received, whether there is any history of aspiration. So everything we take away, whether the patient is having the drug that is being received can cause drug-induced toxicity. So we are accounting all the factors. And then there are 4 people that are sitting on that group, all our consultants that are dealing with the thoracic management. And then they will decide whether this patient will go ahead with the testing or not. Though sometimes we tell the patient to go ahead with the testing, not all patients are tested. But I am just saying that most of the patients we have called for 4 and 5, around 75% of them have come positive. And where we have given the alternative diagnosis, none of have come positive. So though out of 25, only 14 were tested, but that is also a good number actually, we can say.
Okay, that's fine. So are you aware of what the other lab parameters have been, which have indicated that, okay, even if it is the radiological thing is not typical of COVID, these are the things which will mandate COVID testing and stopping.
So lymphopenia we routinely take. That is our this thing, and then apart from that we will take the history very carefully, but because the patients might have across from the DMGs, not only from thoracic, they can be from across the DMGs, whether it is a GI or it is in head and neck, or because in head and neck the chances of a patient who hasn't done morbid surgery, the chance of aspiration is high. So all there are factors that we are dealing in the hospital, and then we sit at this thing, and then we will decide whether this patient has to undergo testing or not. So thankfully our administration says that whenever we send patients, most of the time they don't deny for a test.
Okay, thank you.
Very well answered, sir. So next question we have from, I think so this was answered by both of them. Ullas, would you give osimertinib first line with same enthusiasm? And he says and we had a series of chats over that. Perfect. We can scroll down to next. Next. Again, we had an answer on the chat box for the same. So probably, I think so we are already exceeding our time limits. I should be doing the concluding. I will be concluding in 1 minute. We had an excellent session throughout, an academic feast. We started with a very important data of the insurance companies, and as well as the common patient problems we have, that 25% of our patients do go bankrupt, and Joe Peters gave us a figure that was staggering, that 90% of our insured patients are underinsured by a margin of more than 60%, that we have to keep in our mind. And the moderation of the panel was in view that there are various microfinance options. There is an Arogya card, there is a psychometric analysis which you do for your patients in view of assessment of the repayment of the loans. So options are a lot, and a very important key takeaway is the Oriental India Insurance the order which has come up with the reimbursement of it, and I think so it should be used more frequently for the benefit of our patients. Dr. Ullas Patra guided us through the way of the liquid biopsy, how it's convenient, its concordance, the trials, the Nile and complete study, and Dr. Vamshi took it to the next level to guide the way, the sequence of the TKIs that should be done. Dr. Seventy put an extremely good panel discussion for an uncommon EGFR mutations with the data discussion on afatinib, osimertinib, as well as exon 20, the new options, the positinib and the amivantinib. We had followed by a healthy debate by two of our eminent debaters regarding the N2 disease, and there was a consensus that a single station resectable non-bulky lymph node should go for a curative surgery. The others, like inoperable bulky media, multiple centrally located, should go for a definitive CTRT. And finally, to conclude, Dr. Amit Janu did an excellent job in portraying us the various features of the CORATS staging, from ranging from negative, typical, indeterminate to low likelihood and a high likelihood, with nodules, ground glassings, and consolidations. An important key takeaway again, that the pleural effusions and increase in the nodes are something that we shouldn't be looking as a COVID. And I have the honor and privilege of handing over to Dr. Purvish sir for the conclusion, as this was a key learn away and a academic feast for me throughout.
Thank you, Vikas. You set the ball rolling with the Chakravyuh on breast cancer, and then we moved on to GI, and now we have this one on lung cancer. So, kudos to you for thinking of how to make this all innovative. And with that comment, I conclude this session. And then thank you very much to everybody for active participation. Take care and stay safe.